Good morning, good afternoon, and good evening to everybody joining from different parts of the globe for our continuing series on CME entitled as Visual Clinics in Hepatobiliary Diseases. Today is the second weekend and third day of the conference, and today we are going to elaborate on the advances in diagnostic modalities at various aspects of gastroenterology and hepatobiliary sciences. To take us forward to the journey of advances in the recent techniques of diagnosis in GI tract as well as in the pancreas, we have a galaxy of speakers who are going to give us the woven threads of the recent advances in field of diagnostic imaging by Professor Nordio, who is a celebrated figure from Japan. Then Dr. Govind Makharia is going to tell us the bread and butter of gastroenterology, the functional bowel disease, as to how do we go about managing the complex and difficult problem. We have two giants of pancreatic sciences, Dr. Pramod Garg and Dr. Vivek Kaul, who are going to take us through the journey of advances in management of the pancreatic fluid collection, as well as the approach to the so-called easily looking and casual looking cystic neoplasm in terms of its diagnosis and the therapeutic algorithmic management. Then we have Dr. Rana, who will tell us the basis of the endosonography for the beginners. And finally, we'll end up with recent advances in the bread and butter of, say, US, in which the colonoscopy is in big demand because of the presence of the polyps, which is becoming an increasingly common problem in India too. Is going to elaborate on the recent advances in management of colonic polyps, both in terms of diagnosis and management. With that, I'll hand it over to Ashish for further proceedings of the day. Ashish, please.
Yeah. Good evening. Thank you, Dr. Arora. So we have an exciting day ahead in endoscopy and pancreaticobiliary diagnostic imaging sessions. So for the first session, which is on advances in endoscopic imaging, I would like to invite our moderators, that is Dr. Randhir Sood and Dr. R.K. Vadwa. Dr. R.K. Vadwa is the chief gastroenterologist and director at the Institute of Gastrosciences, Apollo BGS Hospital, Mysore. And Dr. Randhir Sood is the chairman of gastroenterology and hepatology at Medanta, the Medicity Hospital, Gurgaon. So I would hand over to moderators to introduce the speakers as well as the panelists. So Dr. Randhir Sood and Dr. Vadwa, over to you.
Yeah, I think anybody who is doing endoscopy and particularly is involved in enhanced endoscopy, imaging, will know Noria. There's nobody on this globe who is better qualified to speak on, enhanced endoscopy imaging, be it virtual, be it, the chromo endoscopy, and the different evolving technologies of magnifying endoscopy. And today we have Noria with us from Osaka, and he's one of the authority and one of the persons who is, any atlas you take on, NBI, you take on magnifying endoscopy, you will have his contribution to it. And I'll invite you, Professor Guido, to give your talk, and I'm sure the audience will love it.
Thank you for kind introduction. So I share my, can you see my slide?
Yeah, we can see.
Okay. So thank you, Professor Aurora and organizing committee for giving me an opportunity to participate this web conference. Today, I will talk about advances in endoscopic imaging. In this presentation, I will talk about image-enhanced endoscopy for detection, and magnifying endoscopy for characterization, and artificial intelligence as a future perspective. First, what is IEE? The term IEE includes various methods for enhancing endoscopy finding, including color and morphology, using dye, optical, or electrical enhancing method. And magnifying endoscopy is a method to observe small vessels and minute pattern of the mucosal surface by enlargement of the endoscopic images, and it is usually used in combination with IEE. So why they are needed for endoscopic diagnosis? For such advanced cancer, IEE or magnification is not mandatory. However, premalignant mucosal changes or early stage cancer, it is often difficult to identify with only conventional endoscopy because they have subtle color and morphology. So we usually take biopsy to make diagnosis. But if we use IEE, we can improve lesion detection. And with use of magnifying endoscopy, we can improve lesion characterization. And in this case, it enables us on-site decision-making without biopsy. So I'm talking about currently available evidences of IEE and magnifying IEE for lesion detection and characterization. In multi-center randomized control trial, NBI is proven to improve detection of squamous cell carcinoma in the esophagus and head and neck region. And especially the difference is more apparent in head and neck neoplasia. I think this is very good because it is difficult to apply iodine chromoendoscopy in this area. And recent few multi-center studies demonstrated that IEE is also useful for detection of early gastric cancer by contrasting the color of the lesion. Meta-analysis of randomized control trials indicated usefulness of NBI for detection of colorectal adenoma, especially with best Bowel preparation. And another latest meta-analysis of randomized control trials indicated usefulness of different type of IEE linked color imaging for detection of both colorectal polyps and adenomas. Next, how about characterization of GI neoplasia using magnifying IEE? For differentiation of esophageal SCC from benign lesion, previously mentioned randomized control trial showed improvement of diagnostic accuracy of magnifying NBI from 57% to 89% compared to white light endoscopy. And one observational study indicated that NBI improved specificity for diagnosis of esophageal SCC even compared to iodine chromoendoscopy and contributed to improvement of overall accuracy. A randomized control trial, which I was involved in, investigated effectiveness of magnifying NBI for differential diagnosis of early gastric cancer from benign lesions. In this trial, 1,300 patients who is at high risk for gastric cancer were enrolled and randomized into conventional endoscopy group or magnifying NBI group. As a primary endpoint, diagnostic accuracy was compared in initial diagnosis method. Then, in patient assigned to white light endoscopy was subsequently received magnifying NBI, and additional diagnostic value was also evaluated as secondary endpoint analysis. In the primary endpoint, magnifying NBI improved diagnostic accuracy, especially specificity for differential diagnosis of gastric lesion. Moreover, in the secondary endpoint, if magnifying NBI is performed in addition to white light diagnosis, all diagnostic value exceeded 95%. Diagnostic accuracy of near-focus endoscopy, which is more common outside Japan, for differential diagnosis of early gastric cancer was also published recently. This result was analyzed as a secondary endpoint of randomized control trial for early gastric cancer detection. According to the data, near-focus NBI showed 88% of accuracy, 61% of sensitivity, and 97% of specificity for differentiation of early gastric cancer. When we compare this result to previous randomized control trial using optical magnifying NBI, the diagnostic accuracy of near-focus NBI was better than that of white light endoscopy and similar to that magnifying NBI alone, but not as good as combination of white light and magnifying NBI optical zoom endoscopy. We speculated that this difference between near-focus NBI and optical magnifying NBI in diagnostic accuracy may be caused by a bit lower resolution power of near-focus endoscopy compared to optical magnifying endoscopy. However, as I mentioned, diagnostic accuracy of near-focus endoscopy was better than that of white light endoscopy. Then, also, usefulness of magnifying NBI for differentiation of colorectal neoplasia and non-neoplasia is also reported. And with magnifying NBI, differential diagnosis of colorectal neoplasia has very, very good accuracy like this. Then, what is future direction? Recent hot topic of artificial intelligence is reported to show better detection and characterization for endoscopic diagnosis of esophageal SCC, and it was slightly better than that of expert diagnosis. Japanese data show that in recorded images, AI show better positive predictive value for early gastric cancer detection with significantly shorter diagnostic time compared to expert diagnosis. So, for example, if we use artificial intelligence system, we can identify the lesion in this kind of bounding box. And it works also with NBI. Previous lesion was a bit obvious, elevated lesion, but AI also works for this kind of very subtle flat lesion as well. And it also works in NBI too, like this. Okay. So, but I would provide my thought of AI. Someone may say that if we use AI, there is no need for use of IEE or magnification for endoscopic diagnosis of superficial GI neoplasia. But I think this is wrong because computer always make very natural diagnosis, meaning red is red and the round is round. So even with AI, cancer with the same color and morphology to benign lesion cannot be distinguished each other. Therefore, even though we use AI in white light endoscopic diagnosis of early gastric cancer, diagnosis accuracy would be similar or slightly better than expert diagnosis. However, it would not be so high because small depressed early gastric cancer shows similar finding to benign depressed lesion in white light diagnosis. However, if we use magnifying NBI, diagnostic accuracy improves more than white light diagnosis because we can evaluate presence of demarcation line or irregular vessel pattern in magnifying NBI images. And this result is achieved by even less experienced endoscopists. This is a benefit of AI. Moreover, it is important to know that even AI cannot make diagnosis of invisible lesion or hidden lesion. Most published data use very clear and clean high-quality images for study material. But it is important to validate that the AI also works for in ordinary clinical situation all around the world. I understand that the endoscopic diagnosis has two domains. That is, technical domain to achieve good images to make diagnosis, and the cognitive domains to interpret the endoscopic finding properly. I assume that in the future, AI would solve issues in cognitive domains. So the improvement of endoscopic practice would be more focused on technical domains, such as good preparation or optimal observation technique, like that. In addition, for new endoscopic technology, expanded depth of focus EDOF has developed for the latest endoscopy. This EDOF technology widens the good focus area compared to optical zoom endoscopy. So this is a new image enhanced technology to contrast the color TXI mode, and it enhances the color of the lesion like this. And when we use optical zoom endoscopy, area of good focus is narrow, so the image is a bit unstable. And during this time, I also maneuver the scope, delicate scope, and also magnifying lever delicately like this to achieve good image. But EDOF, the area with good focus is very wide, so image is very stable. And then we can evaluate the demarcation line and the presence of irregular vessels similar to optical, easily similar to optical zoom endoscope like this. So in summary, for detection and characterization of superficial GI neoplasia, recent evidences support usefulness of IEE and magnification for improvement of diagnostic yield of endoscopy. New endoscopic technology and artificial intelligence will facilitate achieving good endoscopic images and interpretation of the finding. And finally, it is important to remember that for endoscopic diagnosis, achievement of good diagnostic images is dependent on endoscopist's hands. And the final clinical decision making according to this information is done by endoscopist's brain. Thank you for kind attention.
Thank you, Professor Vidov, for an excellent talk, which was very precise and I think is of great value to each one of us. I'll kickstart the questions because you have provided us more time than Dr. Professor Anil Arora has provided for discussion, because you finished your talk 3 minutes early. So, the thing is that in image-enhanced endoscopy works best with the experts. But when it comes to the community level endoscopists or regular endoscopists, and unfortunately, unfocused endoscopists are more in India than the focused ones in IEE, in spite of the availability of the equipment, this does not perform so well. So artificial intelligence is one tool to minimize the difference. But what do you think is required for people like me to increase their skill level?
So I explained in the presentation. So probably we can more focus on improvement of techniques in the future. Probably AI will solve some issues for cognitive factor. But
Right.
sometimes we really misunderstand that the technology solves all the problem. But we still have to, do some more deliberate practice.
Yeah.
I think.
So I'll ask my co-moderator, Dr. Rajkumar Wadhwa, to ask any question, Professor Vedo, before we bring in our expert panelists for it. And I see Professor Naresh Bhatt, who is very interested in teaching, all the gastroenterologists about the videos and the NBI application and interpretation, as well as the NICE classification application. So Dr. Rajkumar Wadhwa, please.
Good evening, sir. Professor Norio, it was an excellent lecture. Now, I do practice Fujifilm, and we have BLI and LCI and CADI in almost a similar category as NBI and artificial intelligence. Yes. Do you think that these does make a difference, that you have a slightly different technology with one company and slightly different technology with another company, or does it confuse the people or end user about the different terminologies?
So thank you for very nice question. So when we think about NBI and BLI, they use almost a similar illumination wavelength light. So I think achieved image is almost similar to NBI and BLI. So, and the clinical result is also similar. BLI is also proven with a randomized control trial that it also characterizes better than white light image. So I think BLI and NBI is the same. LCI is probably a bit different. It's more for detection. But I think it is already, as I mentioned, introduced in my presentation, usefulness for detection of upper GI neoplasia, and even for colorectal neoplasia is already proven with a randomized control trial and meta-analysis. So I think even though different company, principle is similar, so clinical outcome should be the same. This is my opinion, yes.
We have a galaxy of experts who will be joining us. We have people, Professor Tayyab from Pakistan, Dr. Sitaram Chaudhary from Kathmandu Institute of Science and Technology, Dr. Vinod Kumar Dikshit from Varanasi, Dr. Chandi Charan Chaubal from Bhopal, Dr. Naresh Agarwal from Delhi, and Dr. Mayank Gupta from Dehradun. I will now ask our panelists to join with their experience and questions in this regard, in this the emerging field of new technologies in endoscopic imaging.
Yeah. This is Dr. Dikshit actually. I agree with Dr. Randhir what he asked. Though these new modalities, they definitely looks better because they can pick up the early detection of the malignancies, whether it is a CA, cancer gallbladder, or the esophageal or the colonic other things. The main problem remains, as he said rightly, whether they are comparable with the community, because we are working in the community. So it may not be very cost effective actually. Everything will be very costly actually. If we. Then second important part is the training, because unless we are trained actually well, the facilities available at one center. So until you are having a good training, then you cannot, then it may not be actually really you will be doing the justice. And then different type of validation is still required, whether for classifying the different type of regions. So I think this is too early actually. It definitely looks like a more promising modalities. There are many more what Dr. Nehru had described. And what we require is basically a good classification understanding, a good training. At the same time, it should be made little cost effective, because we are working in the government setup, we know how poor the patients are there. So hardly we can actually perform these tests in the really those people. It may be only confined to the corporate sector where the people can afford. Thank you.
Professor Chbd, any questions further?
Mute. Unmute.
Naresh, you can join in till that time.
Either
Yeah,
I think endobrain is already in practice in Japan. It has come to now almost like from research tool, it has now come on the clinical side. What I'm saying is you have a lesion, artificial intelligence, it's a malignancy, do a biopsy, first a biopsy, it's still negative. So which one are you going to believe at this point of time?
So that is also I mentioned in the presentation. Probably AI is also one of the information. So like endoscopic images or magnifying images, AI is also one of the information. So collecting all these information, final decision making is made by clinician.
What I'm saying is if you have a divergence, for example, the forceps biopsy says no, AI says yes. Which one are you going to believe now?
Probably AI is not 100% accurate because I also show that if it is used in a different modality, accuracy is almost one level. So according to all these comprehensive, interpretation, we can decide. So AI is not always 100%. This is my opinion.
Professor Nurio, since we are talking about the newer technologies and advanced imaging, I was reading about introduction of amber light in, these are all blue, violet, blue, red, or green. And introduction of amber light in the diagnostic modalities can help us in detection of GI bleeding. Do you think that will be a new area which we can look forward to?
You mean the RDI?
RDI.
Red dye, yeah. I also try in our clinical practice, especially we are doing a lot of ESC practice, and during the procedure we have a lot of spotting bleeding. Not a lot, but some often we experience. So at that time, it's very useful to identify the bleeding point. So I think it also works for emergency bleeding case as too. So we feel it's really good for clinical practice. So I think you have to investigate it in a clinical study so that you can actually get good data. I think.
Yeah, sorry.
Dr. Udo, do you see any possibility in Japan, because finance is not a big problem and you are always the leader in the endoscopy advances imaging. Do you see a possibility that in Japan you will altogether recommend for stopping the white light endoscopy in future? Is there a possibility like that?
That is very difficult question. Good question, but difficult question. Sometimes very enthusiastic endoscopists say that it is, image enhanced endoscopy will take place, the white light endoscopy. But in my understanding, usually image enhanced endoscopy really enhance some specific image area of light. So maybe good for diagnosis of superficial neoplasia, but in our clinical practice, we have many different diseases like benign disease or bleeding or something. So in specific purpose, maybe Ieee is better than white light, but I don't think it's really, replace all the clinical practice, endoscopy practice. This is my opinion.
Yeah, in Nepal, for us, the problem is that very occasionally only we are able to detect these cancers in early phase to cure. Sometimes we are happy. Mostly it is only palliation. So our concern is how to do maximum number of endoscopy in the community. Maybe we are hundreds of gastroenterologists in Nepal because of Professor Dr. Anil Arora, lot of advances for us in last decade. But we are realizing probably we will need to double, triple the number so that the community people get the endoscopy done. And the suspicion, when the suspicion is there with the white light endoscopy, then they can be referred to the tertiary center where these NBI experts, I think, will practice only, we will learn. Somebody has to go ahead. So we fully believe that it's very useful technique, NBI technique. Advances are useful, but all over the country, it won't be possible in Nepal.
Sometimes, I also mentioned that sometimes we misunderstand technology, solve all the problems. So probably NBI or some IEE is one of the clue to change our mind. But the most important thing is the changing of mindset, maybe. So, for example, Japanese endoscopy detected early lesion, maybe 1960s or 1970s by fiber optic scope.
That's right.
So even at that time, they can detect some lesion. Of course, IE enhance detection. So I think if we really change, knowledge or our idea, I think even we use conventional endoscopy, we still improve somehow for the diagnosis.
Thank you.
That is
So, Ido,
my idea.
is there any
Yes.
difference?
Professor
sorry.
Norio.
Professor Nuri,
Can I
a
speak
small
now?
question. Are you using some fluorescent material during your NBI also, just to have more
No.
upgrade?
No, that is on just the optical technology. So just place a filter in the light source. So just pressing the button. That is also a good point. So you mentioned that sometimes it's difficult to distribute in the community setting, but most of the endoscopic companies really want to promote such things. So probably maybe 1 generation or 10 years or even 5 years, every company products equip such technology. So when to start is just in our side, in our decision.
Professor, is there any difference in combining technology of artificial intelligence with xenon versus LED? Which one is better, LED or xenon, or they're equal?
I think it's equal. So AI just identify the image recognition. So even it uses a different light, I think it's if the endoscopic image represents the characteristic finding, I think it's the same.
Professor Norio, I have another question, and I think Dr. Naresh Bhatt, who has a phenomenal experience in India, can also join. When I started early for applying these techniques into clinical practice, what I found confusing is the plenty of classifications which existed in these field. Different companies have put different classifications, like Olympus promotes a particular type of classification and Fujifilm users promote a different type of classification. Do you think it is a time for us to now, combine all these classification into a universal classification? As you said, technologies are similar, so that it becomes easy and more, applicable to a beginner who is more confused with these classification than actually they should be.
Very, very important thing. So in my understanding or idea, usually experts really promote their own classification or something. Because as I mentioned that the Fuji BLI or NBI uses almost the same principle and same illumination light. And we see the same vasculature and the surface structure. So we have to have some more merged classification. So I think it is possible if we really understand the principle or characteristic principle finding. So I think we can use the same terminology even for different methods. So
Raju,
I
agree
totally agree. Yeah.
I agree with you that there has been a lot of confusion, but then that confusion is not limited to us. Even in Japan, for the colonic thing, they had 3 or 4 until they merged it and they now have a JNet classification. So I think now we have fairly clear things that for squamous cell carcinoma esophagus, we have a Japanese classification, Japanese Endoscopy Society. We have one for Barrett's. We have for CS stomach and colon. So I think it is now, it does exist. And as Professor Noria said, it is not limited to just users of NBI, but across all sort of companies, whichever one that you're using, because ultimately the images are fairly similar. The hues may be a little, a little more yellow, a little more brown, but they're essentially the same. You're seeing the vessels, you're seeing the surface pattern. So I think now one doesn't find too much of a problem in adapting a new classification and using it in daily practice.
Final question before we, wind up, Professor Vedo. Which is your preferred artificial intelligence technology? Because there's so many coming up in the market, and so tell us about your preference.
So difficult question because still different company, but still not yet proven for the high quality of evidence. So still amateur AI technology in clinical practice still. So maybe we have to wait the more big prospective randomized trial to prove the efficacy. Sorry, I didn't answer well.
Thank you, Professor Vedo, and thank you, my co-moderator Rajkumar, and all the panelists for joining in. And I can see some worry coming on Professor Anil Roda's face that we are exceeding time. So over to you, Anil.
Thank you.
Thank you.
Thank you, sir. Ashish, you can carry on.
Yeah.
Thank you so much, sir.
Thank you, Dr. Sood. Thank you, Dr. Vadva. So we'll move on to the next session, which is what is new in the management of functional bowel disease. And for this, I would like to invite our moderators, Dr. Deepak Lahoti and Dr. Naresh Bhatt. Dr. Deepak Lahoti is a Senior Director of Gastroenterology, Hepatology and Endoscopy at the Max Hospital, Patparganj. And Dr. Naresh Bhatt is the Chief of Gastroenterology and Liver Disease, Aster CMI Hospital, Bangalore. He is also the former president of ISG and SGEI. So over to you, Dr. Naresh Bhatt and Dr. Deepak Lahoti.
Thank you, Ashish and Anil, for having me here this evening. And I welcome you to this session on functional bowel disease. And we have my good friend Govind Makharia, who's going to talk to us on what's new in this area. Govind, to all of you, is a dynamic professor at the All India Institute, New Delhi, and also the dynamic secretary of the Indian Society of Gastroenterology. He has a lot of interest in luminal gastroenterology, his areas of interest being celiac disease, functional bowel disorders, IBD, and of course into colorectal cancer as well. Before Govind starts, maybe Deepak, you'd like to introduce the rest of the panel? Unmute yourself, Deepak.
Yeah, I think let the speaker finish his talk and then I will introduce the panelists.
Govind, it's all yours.
Yeah.
Thank you very much, Dr. Arora and Dr. Ashish, for very kind invitation, and very good evening, everyone. Thank you, chairpersons, Dr. for for your kind introduction. If I can share my slide and the slide visible now?
Yeah, they are visible.
Yes.
You can make them full screen. Yes, they are.
I will, yes. Yes. Just 1 second. Right. So, as this topic is, I believe it's a very important topic, that what's new in patients with functional bowel disease. I have no conflict of interest. So before I go to my talk, I'd like to cover a couple of case scenario and to highlight the importance of why we need to change the way we see IBD or IBS now. So this is a 45-year-old female who came to us with altered bowel habit for the last 5 years, had abdominal pain, had postprandial discomfort and bloating, and had no constitutional symptoms. She also has episodes of palpitation, had a chest pain, has gavrat, tiredness, and lack of sleep. For this, she went to multiple doctors, and she was prescribed symptomatic care, including antispasmodic and laxatives. but there were no response. Over time, she visited 4 physicians and multiple tests were done. And her symptomatic, her medical records keep increasing in volume, but she only had a partial response. Bring to another patient, this 46-year-old male who was symptomatic for 10 years with chronic constipation, had no urge to pass stool, and he used to pass stool once every 1 week, and hard stool. He used to pass the stool only once a week. He had abdominal pain, postprandial fullness, but no weight loss and other features. He was also diagnosed with IBS, but he only had a minimal response to treatment. We have another patient, she's a 52-year-old female, 3 years symptomatic, chronic large bowel diarrhea, postprandial fullness, multiple other symptoms, including restlessness, tiredness, migraine, frequent crying without any inducing factor, and lack of sleep. She was diagnosed to have IBS-D by a physician and treated, but again, she didn't have much response. So I give you a 3 clinical scenario, which is a common clinical happening, which we see day to day in our clinical practice. But I told you that all 3 did not have great improvement in the symptoms. Why it is so? The first thing, when this patient comes to us, and once we see these patients coming to us from many doctors, prescription and once thick files, firstly what we do is ignore and stigmatize. This is a functional bowel disease. Don't put your time and write a prescription, and therefore the file keep increasing its volume. Second thing, we try to put everything together into one diagnosis, which may not be always true. We try to look at only GI symptoms. Since we are GI specialists, we try to look at only chronic diarrhea, constipation, or pain abdomen, and we don't consider other aspects. And we compartmentalize the diagnosis to only GI, while the patient can have multiple other symptoms, multiple other somatic, multiple other psychiatric illnesses. And in addition, we address only symptoms. We provide only symptomatic care. So this is how we treat IBS today. And even our treatment drugs, even the best drug which is available to us, even after randomized controlled trial, the response rate is less than 50% and just 7 to 15% over placebo. It means we don't have effective care of these patients. We learned over time that all IBS are not same. Therefore, they cannot have similar prescription. And therefore, we need to change the way we look at IBS or other functional GI disorders today. And therefore, I'm going to highlight what's new in the changing concept in patients with the functional GI disorder. And these are my agenda to discuss, and we come to each one of them one by one. The most important thing which has come now, that the people who work in IBS, I'm not one of them, but my colleague Uday Ghosal and many others, they work in this field, and everybody realized that the way we look at IBS today is not the way we should. Therefore, the whole FGID group has been redefined as disorders of gut-brain interaction. That's called DGBI. And we will not use the term FGID now. We will use the term gut-brain interaction. And why it is so? Earlier it was called functional. The term functional for both for doctors and patients looks like a functional disease, a psychiatric illness, or some kind of a somatization disorder. And therefore, we always underplay it. It's not so. Therefore, these disorders are now called disorders of gut-brain interaction. And why it is so, we'll come back. And this occurs because of multiple GI physiological abnormalities, which are part and parcel of DGBI. That's a GI tract motility abnormalities, either increase or decrease. Increase IBS-D, decrease constipating type IBS. They have increased visceral hypersensitivity, more frequency of stool, more symptoms, more bloating, altered mucosal immune functions, altered microbiota, which is very important, and altered CNS processing of these factors. And all together, they lead to a symptom complex of IBS. Earlier, it was called brain-gut axis. Now it's called gut-brain interaction. So gut leading to these factors. And it's also known that for all FGIDs, if you look at all of them, and there are studies available, that in 50% of patients, the primary abnormality is psychological distress, early part of life stress, some kind of sexual trauma, some kind of other major stress during early part of life, and they later developed a FGID. But in 50% of patients, the primary abnormality in the GI tract, and that leads to secondary brain involvement. True. And of these, if you look at how it works, and how it works is this pathway, that in 50% of patients, the GI tract is abnormal. And why? How is it abnormal? They can have multiple factors. For example, if they have an infection in the GI, if there is change in microbiome, and most important, let's start from diet. The diet is diet-induced inflammation. So once we ingest a lot of our food and food antigens, as we take our food, a lot of antigens are also ingested. So these antigens are picked up by antigen-presenting cells. These APCs then induce the immune cascade, and these immune cascade leads to T cell infiltration, type 2 immune reaction that also lead to mast cell infiltration, and all this what we call a kind of inflammatory state in the GI tract. And this can persist because person is taking diet every time. There may be some factor in the diet which induces inflammation. Also, that can induce dysbiosis in the gut. That can also induce, so all these factors, once we have mast cells infiltration, once we have immune inflammation, they also sensitize neural cells, the enteric nervous system. That neural cells that leads to visceral hypersensitivity, and that secondary brain involvement, and that leads to all these symptoms. So therefore, in 50% of patients, gut is the factor which leads to immune activation and brain activation. And therefore, there are multiple factors do happen, and multiple physiological abnormality do happen in these patients with IBS. So IBS is no more a functional disease. This is called a microorganic disease. They may appear normal, but if you look at microscopic, you find a lot of patients with IBS will have a mast cell activation, will have more serotonin levels in the GI tract. They will have a dysbiosis. They will have bacterial overgrowth. They will have motility abnormalities. So they are not functional. They are all microorganic. They are not visible to us, but if we start looking at it, we'll find multiple abnormalities. And all of these convert into symptom complex. So therefore, this disease, now called DGBI, can have a component of motility, component of visual hypersensitivity, component of immune dysfunction or immune activation, can have a dysbiosis, and all these lead to central altered CNS processing of these information. So with this background, let's come back that how do we make diagnosis and how do we consider all these factors into consideration. We can make diagnosis of IBS by Rome 3 or Rome 4, and we make a positive diagnosis. Many times we leave diagnosis as a negative diagnosis, and many of these patients have pain abdomen. They find ultrasound gallstones, which are asymptomatic. The patient has a FGID, but you find gallstones, I treat gallstone as a cause of pain abdomen. And it is seen that these patients with IBS is threefold high risk of getting cholecystectomy and also of appendicectomy and hysterectomy. Therefore, make a positive diagnosis at the outset. The point I want to highlight today is also the way we look at the symptom complex. And this chart, which is extremely important in clinical practice. Many patient comes that I passes three stools a day, but I'm still say I'm constipated. 3 stools a day, constipated. How is possible? And if you saw the chart, this I pass to like, this is the type of stool I pass. It's not IBS-C, this is IBS-D. And if you look at this chart, this is a normal stool, type 4, type 3, type 2, type 1, type 1 to type 1 into a typical constipation, type 5, 6, and 7, typical diarrhea. And why it is so? This tells us that how much water is there in the stool. And if we have a more stasis of the stool in the colon, there will be more water absorption, right? And therefore, they become from 3 to 2. So this stool becomes more dehydrated. And as it becomes more dehydrated, it breaks into small pieces, becomes type 1, pellet-like stool. So this tells us that there's a more stasis of stool in the colon. Type 1, type 2, constipation. More frequency, even more frequency, but this type of stool will be IBS-D. So using this tool is very important. We can download it on our phone and use in our clinical practice in outpatients. And I believe this is a very, very important thing to do. And based on that, based on this chart, you will define IBS-C, IBS-D, IBS-M, and IBS-U. If you have more than 25% of stools per week are like a type 1 and type 2, and 25% less than this is type 5, 6, and 7, we call it IBS-C. IBS-C means most of the time patient is passing type 1 or type 2 stool. IBS-D means most of the time patient is passing type 5, 6, 7 stool. All right. Second point, that we need to, every patient with IBS do not require investigation. Is important to realize. We need to really find out who are the patients who require our attention. And the good clinical history will tell us that if there are alarm symptoms, certainly this patient will require investigation, but everybody will not require investigation. And somebody will require specific investigation. For example, patient number 2, which I showed you just now, that patient had passed stools once a week. It's not normal. It's a slow transit constipation. And slow transit constipation, we need to look at the GI transit studies. So many patients will require specific investigations. Not all will require all investigations. Also, it was believed that treat all IBS alike. It is not so. IBS will be of a different severity, mild, moderate, severe. And we can define severity of IBS is very important as we do for our IBD, mild, moderate, severe activity. Or for many other diseases, we define severity. It's also too important to define severity of IBS or FGID. And again, looking at the symptoms, we can have 5 questions, simple to do. Frequency of pain abdomen, frequency, severity of abdominal distension, dissatisfaction with the bowel habit, and quality of life. And put all of these into a scale of 100. Patient will score in the scale of, say, visual analog score, a scale of 100, and based on that, you'll define mild, moderate, severe. More than 300 becomes severe. And severe disease patient will require specific care. Also, IBS patients are not alone. They do have other associated FGID. They do have other associated somatic manifestation. They do have associated psychiatric manifestation. We need to know all about them. If we know about them, we'll also address each one of these. The Rome, Rome Foundation, which have been the building block for FGID, never realized that patient with IBS will have other comorbid illness. And therefore, Rome always says, make one diagnosis, is IBS or functional dyspepsia. But in practice, this never happens. One patient can have multiple other FGIDs. And if you treat only IBS, the symptom of bloating will persist. If you treat bloating, symptom of IBS will persist. And therefore, there have been a change in thought in the Rome Foundation, which Uday tells us. And now we have a study published this year that looking at people, this is an internet survey, looking at individuals and asking questions. And it was found that almost say of those patients who have a disorders of brain interaction, almost 40% have other associated FGID. If they have IBS, they do have a other disorder, and they could be other gastrointestinal disorders, they could have other esophageal disorders or inorectal disorder. So therefore, one patient with IBS can have a multiple other FGID, and this is a new concept which is evolving. We need to address each one of them.
Govind, you have less than 3 minutes to go.
Really?
Yeah.
Oh my God. So then all those who have those patients who have a one abnormality will have a more abnormality. They will have more psychiatric abnormality in this. Furthermore, let me have to skip a couple of slides then in that case. Okay, the point I want to highlight in the rest of my time is the changing concept. So with this concept of having multiple disorders in patients with IBS, we need to define IBS as a diagnosis in a multiple dimension. As we do hepatitis B virus, we look at E antigen, we look at DNA, we look at liver status, we look at fibroscan, we look at ultrasound, we look at SCC. We look at all of them together, we get plan. Same in IBS. We need to look at categorize. Is IBS C, IBS D, IBS M, IBS U. Call is mild, moderate, severe. Define what is etiology. Either any physiological abnormality in this, like for example, post-infective IBS, food sensitivity, or etc. You define physiological abnormality like slow transit constipation, bacterial overgrowth, and psychological modifier. And we need to define all 5 of them and address all 5 of them in the treatment of FGID. So I will skip a couple of more slides. So what is new in treatment? So we have been treating these patients according to constipation, diarrhea, and pain abdomen. But now we treat this patient depending upon what is the physiological abnormality in them. This is a new approach where you address each one of them. You address inflammation, you address GI pathology, you address GI function, you address gradient, you address immunomodulators, and all together is the therapy. And what is the evidence? Wonderful study published last year. This is a randomized controlled trial where 2 groups, one group is given usual treatment, what we do today. The other group was given a multidimensional treatment addressing each factor. What is multidimensional team? They had a gastroenterologist, they are residents of gastroenterology, dietitian, psychiatrist, behavioral therapy, like those who provide the biofeedback, and also gut-focused hypnotherapist, team of them. What happened?
Your time is over. I'll give you half a minute more to summarize.
All right, then I'll stop here. So in this group, what we've seen that those standard care only 50% improved, but those given multidimensional therapy 84% improved. Remarkable change. Therefore, multiple dimension therapy is the treatment which we must offer. And coming to my last slide to summarize it is that we need to rethink about the IBS the way we look at. This is not only, if we don't call it now FGID, we call it disorders of gut-brain interaction. You make appropriate diagnosis, subtype severity, define comorbidity, define physiological abnormality, define and summarize into a multidimensional clinical profile, and treat this patient in a more holistic way rather than a symptomatic way. With this, thank you very much.
Thank you, Govind. Deepak, would you now take over the session?
Yeah, thank you, Dr. Govind, for a remarkable insight into recent concepts of IBS. And now we have panel discussion, open question and answers. Among our panelists are Professor Kartar Singh from Chandigarh, Professor Manisha Dwivedi from Allahabad, Dr. Nirmal Yadav, Dr. Rajesh Senani from Jaslok Hospital, Mumbai, and Dr. Nishant Verma from Bikaner. So the session is open.
Govind, you brought out a very interesting approach of a multidimensional and try to involve each of these dimensions in the diagnosis. But ultimately, how does it change therapy? Pharmacological therapy, has it changed big time, or is it still sort of restricted to symptomatic treatment and tricyclic antidepressants?
Now, again, since we never thought about it, since our approach was more simplistic, that looking at only diarrhea, constipation, antispasmodics, therefore there's no research in that. And the whole, so therefore we were not focused. Now they're focused. There's a need for defining new treatment. And also of that, now there are central modulators, like antipsychotic drugs, which are antidepressant. Multiple number of new drugs are now being explored in this group. So it's just the start of a change of our mindset from looking at symptomatic care to treating patients in a more holistic way. So at this point of time, may not have a great drug. For example, IBS-D. If you have IBS-D, you will always test for SIBO. If you find SIBO positive, you give antibiotic. In IBS, you will not give antibiotic. But since we are thinking of SIBO now, 30% of IBS will have IBS-D will have SIBO. Therefore, test for SIBO, treat for SIBO. Not only that, the bile acid. Now, 1/3 of patients with IBS-D have a bile acid malabsorption. Again, this is a new finding, a new observation. Therefore, if you observe that they have bile acid malabsorption, difficult to test, we don't have test available. But in those centers where test is available, giving bile acid sequestration therapy will be an important aspect. Also, if you have a gut microbial modulation, in that case, you will do FMT. Although trial of FMT have not shown till now any promise, but there are only 4 trials available. But all the 4 trials suggest that we don't have a group of that, so it doesn't show any efficacy. But again, we need to go further on this.
Deepak, can I ask a question?
Yes, sir.
Deepak, if with the permission of chair.
Yeah, please.
Yeah, Govind, excellent presentation. You have defined a complex which till recently we have been trying to dump it into the waste basket as a functional disease. But at the heart of our heart, we did know for a long time that we do not understand, because these are the very patients who will come to you even during pandemic, even during rainy days and season. They'll come and sit and they'll give hundreds of dollars to get cured from the disease. But the type of pathogenesis you have tried to mention, how do we get onto that problems of say disruption in the mucosa of the intestines, hypersensitivity? There is no objectivity. At the end of the day, as Dr. Naresh very well said, what you do is you rule out an organic disease, then we know that most of these patients will improve depending upon what symptom they have, whether it is anxiety or depression. At the end of the day, it boils down to that only. Till you have objective criteria of sub-classifying. It is a good concept, but as of now, we have no objectivity.
No, absolutely. It's totally a new concept. Again, we have to go further. It is similar like IBD, the stride, that stride concept that treat the target. And again, we don't know every steps how to do it, but now thoughts are open. Therefore, a lot of groups will work on it, and we'll have an answer to this. But again, we start changing our thoughts that the FGID are not the way we should look at. We should look at in a more pragmatic way, in more physiological way. So again, we don't have answer today, but likely that we'll have a more research in this topic.
Dr. Govind, am I audible?
Yes, ma'am.
Yeah.
All right. Now, what do you think of eradicating H. pylori in functional dyspepsia?
Ma'am, we had a debate last week by Dr. Uday and Usa, and there's opinion varies. But in the Western countries and even in Asian countries, the guidelines that in functional dyspepsia, if you have H. pylori, treat that, eradicate H. pylori. And in 10% of these patients, if you eradicate, there will be a prolonged symptom relief for at least 1 year. So they are called HP-induced gastritis or HP-induced functional dyspepsia. But in all others, we don't have any consensus. We don't have any guidelines in our country. But personally, I believe that we should start thinking more positive way to eradicate H. pylori. There are many challenges, but again, we need to be open about it.
And what are your views about using gabapentin for visceral hypersensitivity in IBS?
Yes, ma'am. They are now, as I said, that a multi-dimensional clinical profile, and if you address those patients who are resistant to treatment, if they have a increased frequency, if you have a physiological test like endothermometer is normal, the only issue is that more frequency, then one can use this in a low dose. Yes.
Thank you.
Dr. Govind, by the time a patient reaches a gastroenterologist, he has everything with him: endoscopy, colonoscopy, CT scan, ESR, thyroid. Still is not happy because a big file is just a culmination of everything which a gastroenterologist thinks of. Then how do we start looking for the cause then?
So if you look at
because at the end of the day, everybody repeats everything else. He goes to 10 patients, 10 doctors, everybody does an endoscopy, everybody has an RUT positive, everybody repeats a CT, just to be sure that you're not missing out anything. That is possibly because you do not know what is happening at the level beyond the mucosa, submucosa, nerves, gut-brain axis.
Yeah, exactly. So the more important, that's what the new concept is, that don't make a negative diagnosis. IBS make a positive diagnosis. If a positive diagnosis, majority of patients will not require any investigation. If they have a simple pain, abdomen, diarrhea changing with pain getting better with passage of stool, IBS-C, IBS-D, majority of them will require simple symptomatic care, nothing else. But those patients who come to us to GI after primary and secondary care referral over years, these patients require our attention. We need to sit with the patient. Don't look at the file. If you look at the file, you already made your mind, okay, I'm going to write my prescription and that's it. That's not true. We need to go about it. For example, I give an example, the patient number 2, who had a typical slow transit constipation. And if you keep giving any therapy, you're not going to work. If you know is a slow transit constipation, I give him the gut motility agents. I'll give him something like Dulcolex. I give him something like a sodium picosulfate, because I want the gut to move. I want colon to move. At the same time, I'll give him Pegleg, because to move the stool down to the rectum and so that it can pass, right? Or we can use prochloropride. But if you're giving him simple other drugs, we're not going to help. If you give fibers, it's going to worsen the symptoms of this individual. So therefore, if I understand what is the cause, then I can treat it better.
Dr. Nirbal, you had some comment?
I just want to say something. This is very nice presentation you have given us. But at this moment, to have this multidisciplinary team together is very difficult in this COVID time. And not only that, only 5% patient will be going to specialist. 95 will be with us. I'm not a gastroenterologist. And the thing is, for us, it is a simple thing that rule out any organic cause. And I have listened to both. And I have listened to the previous hepatobiliary also by Dr. Usha Datta. It is almost the same thing. It's with a little bit of change of cover. And of course, it is a new concept you are telling us, but only 5 to 10% patient will be reaching you. The rest will be the same. That is, remove any organic disorder and treat them just for a functional
modality treatment.
That's exactly. I think we need to think away. Like, for example, an IBD is the best example, or rheumatoid arthritis is the best example. In rheumatoid arthritis and IBD, the way we treat, we don't treat that way now. We treat IBD now more different way, more pragmatic way, more holistic way, looking at the healing of ulcer. Because we know, because most IBD, and I always wonder that we can treat a complicated disease because we know pathophysiology. We can address each of the abnormal pathophysiological factors. We treat each one of them. But why in IBS we fail always? In IBS, in some number, in majority we succeed because majority of them are mild disease. But in some number, maybe I would say 20-30% of all patients with IBS, which are moderate to severe, we don't see them like they have a specific abnormality. So therefore, now changing concept, and more important, the Rome Foundation, which have been the founding element of this kind of disorders, they have been more liberal earlier, that symptom-based diagnosis. They give license to all the physicians around the world. Okay, 3 symptoms, IBS, treat the way you treat. But now, with more inclusion of more people in Rome Foundation, there's more thoughts coming up in the group, and therefore we have more openness into the whole science of FGID. It's going to be quite exciting in coming times. I think we'll learn more about this disorder. It is more than what we know today.
Dr. Govind, you spoke about the antigens and subsequent immune activation. What is the information on gluten withdrawal? Because there was a wave of gluten withdrawal benefiting IBS patients. What is the current information?
So in lack of time, I didn't show that. I just said diet is important therapy. And many patients with IBS. So symptom of IBS like pain abdomen, diarrhea, constipation, bloating, all these can overlap with multiple other diseases. For example, celiac disease. For example, non-celiac gluten sensitivity. For example, microspiculitis, right? So if you look at all IBS patients, if you screen them, almost 4 to 5 will be celiac disease of all IBS. And if IBS-D is more likely to have celiac disease. Number 2 is non-celiac gluten sensitivity. That those patients with IBS, and if you give them gluten-free diet, almost 10 to 15% will show response to treatment. So non-celiac gluten sensitivity is the diagnosis, but you are treating them as IBS because they have a diarrhea, they have a constipation, so they will make clinical diagnosis of NCGS as IBS. Right? So these are, again, evolving concept in this.
Okay, last comment from Dr. Kartar Singh. We've not heard him. Sir, can you unmute yourself and make a comment?
So unmute yourself, sir.
Can't see him on the screen.
Sir, you're not audible, sir. Sir, you're not audible, sir.
I think he has clicked it twice.
So can you click once, sir?
Only once.
Unmuted once.
Yes, sir. Yes.
Yes. So the microorganicity of the process needs to be made macro. That means the gastroenterologist, whosoever has come to know about the patient and is having that datha of papers in front, after going through the whole exercise, then rather than referring the patient to many more people, now he needs to make the micro as macro. That means explain to the patient. The patient needs to be made half doctor. So that is the crux of the management, that the patient needs to be explained about his symptom genesis. And that will take around 20-30 minutes from the gastroenterologist for a given patient to explain to him with the help of visuals and the rest of the paraphernalia at our command. That may help the patient out rather than referring to all those gamut of polyclinic people who will again like to go through the whole exercise and spend much more time, their own time as well as the patient's time. So what do you react about it? That the gastroenterologist, with the help of visuals, should make the patient half doctor about the pathogenesis of the process.
No, it's a comment. Just I think leave it as a comment. Rajesh, do you have anything the last minute to add, and then we close the session?
I agree with what Dr. Kartar Singh said actually, and in fact, if I have my known IBS patient taking an appointment, it's always the last appointment because I know I can't rush them. And there is no point rushing them because unless you spend time with them, you're not going to be convinced of the positive diagnosis that Dr. Makharia is telling us to make in them.
Okay, I think we'll end this session here. Thank you very much, Govind, Deepak, my moderator, and all the people in the panel. Thank you very much. And thank you, Anil, for this opportunity.
Thank you so very much.
Thank you.
Thank you, speaker. Thank you, Dr. Lahoti and Dr. Bhatt, for this exciting session on functional bowel disease. So we move on to the next session, that is the current management of acute pancreatic fluid collections. And for this, I would like to invite our moderators, Dr. Subhash Gupta and Dr. Sandeep Lakhtakia. Dr. Subhash Gupta is the chairman of Center for Liver and Biliary Sciences, Liver Transplantation and Biliary Sciences at Max Hospital, Saket. And Dr. Sandeep Lakhtakia is the director of endoscopy and EOS at Asian Institute of Gastroenterology, Hyderabad. So over to you, Dr. Subhash Gupta and Dr. Sandeep.
Hi, good evening. Is Dr. Subhash there?
Yeah, I'm very much here.
Hi,
So
Subhash.
perhaps Pramod, I know for many years, both from All India Institute and even now. So perhaps you can say a few words about him. All I can say is a brilliant person, brilliant clinician, and a very dear friend.
Welcome.
Thank you.
We also
like to
invite
thank-
an analyst here who will be part of the program. May I request Dr. Anil Agarwal, Dr. Shaukat Chaudhary, Dr. Suraj Kumar, Dr. Arun Gupta, Dr. D.K. Singh, and Dr. Goldie Logjam.
Only Dr. Goldie is not able to join.
Okay, but others are there, I believe.
Yeah.
Okay. I think let's start the ball rolling, Dr. Pramod.
So thank you very much. First, I'd like to thank Dr. Anil Arora, my dear senior from AIIMS, for giving this opportunity to talk about management of acute pancreatic fluid collections. And I'm so happy that both Sandeep, who is an expert in this area, and Subhash, my dear friend, and for so long are moderating this session. So, I'm not going to talk about this today. If you're hoping that there is a large collection, there is a metal stent, you put it in and the patient is all right. This is not management of acute pancreatitis. I can tell you that for sure. So let me begin by giving you some of the cases that are typically seen. This is a 55-year-old lady, came with abdominal pain, raised amylase. She had SIRS 2x4 criteria. Her oxygen was 90% on 2 liters of oxygen, meaning thereby she had very early onset mild respiratory dysfunction. Ultrasound shows a bulky pancreas and small fluid collection, and she was diagnosed to have acute pancreatitis, and a CT was not done. Usually CT in such patients in whom diagnosis is very clear is not really required. And that's why I'm not discussing the merits and demerits of that. Between day 2 and day 4, she had fever up to 101, counts for 14,500, and creatinine increased to 2.4. Ultrasound done again showed a small fluid collection and mild ascites. So at this junction, the reason I'm showing these figures is that if a patient has got fever in the first week of illness with raised counts, please do not think the patient has acute infected collections. So this is not the time period for infected necrotizing pancreatitis to set in. That takes much longer. So in the beginning, this is because of the pancreatic and peripancreatic inflammation that you find fever and raised counts. But here you see the creatinine is on the higher side. So the concerns on day 2 to day 4 or in the first week of illness is not really pancreatic fluid collection. She had small collection, but I'm not worried. This mild ascites, I'm not worried. The concern here is organ dysfunction, which is the key determinant of survival in these patients very early on in the disease course. And this organ dysfunction could be either early or late. And this could be either because of the pancreatitis per se, which is the case in this particular patient. This is what we call early or primary organ failure due to pancreatitis. And some patients may develop late or secondary organ failure because of sepsis, which occurs in 3rd, 4th week of illness, generally speaking. And this is what we described a couple of years ago, that we must understand organ failure, its cause and time, because that contributes separately and preferentially
to the mortality in these patients. So this is the paradigm of acute pancreatitis. So you have pancreatic, peripancreatic inflammation and tissue injury, which is what necrosis is. And this leads to release of damage-associated molecular patterns, which leads to systemic inflammation, for example, in this patient, which leads to primary organ failure. And some of these patients develop infection of the necrotic tissue known as infected necrosis. And this may again lead to secondary organ failure. You would be wondering that why am I discussing about organ dysfunction when I'm supposed to talk about pancreatic fluid collections? The reason there is that these are the patients who are extremely sick in the beginning, and we must concentrate on organ dysfunction in these patients rather than pancreatic fluid collections. And if you look at the three series that I often quote, one is from Ames, the other is from Dutch pancreatitis group, and third is from Spain, all published actually remarkably in 2018, and all three showed a high mortality of about 40%. In fact, the Spanish study showed 50% mortality in patients who had persistent early organ failure. So please keep that in mind whenever you see a patient with acute pancreatitis and fluid collection, because that is the key for survival in these patients. And this is at a time when necrosis and infection, which is what we're going to discuss today, are either absent or evolving. So that is the importance of early organ failure. Now, coming to how do collections develop and how do they evolve, what can we do? For the postgraduates, let me just remind that the revised Atlanta classification divides pancreatitis into interstitial and necrotizing. In interstitial, you have acute pancreatic fluid collections which may either resolve, mostly resolve actually. Some may develop into pseudocysts, less than 10%. And in necrotizing, you have acute necrotic collections, which may resolve, usually do not, and then develop into what is called as world of necrosis, which may remain sterile or infected. But the problem is in some patients, before they develop this world of necrosis, at this stage of acute necrotic collection, they may develop infection, which is called infected necrotizing pancreatitis. And this is something which is rather difficult to treat. And I'll show you some examples of that too. This is acute pancreatic collection. This is acute necrotic collection. And this is a patient with infected collection where you see air within it. And this is a classical example of a pseudocyst. And here is a world of necrosis. You find fluid here, whitish on T2 MRI. And the black thing here is the necrotic debris, classical example of a world of necrosis. And this can be also seen on abdominal ultrasound. You see fluid and you see necrotic debris inside. So in this second and third week of illness is when we are concerned about the fluid collections. In this particular patient, organ failure is improved by day 7. She had no fever. A CT was done which showed this small fluid collection with necrosis, but because the patient was improving, no intervention was done and she was discharged home. The take-home message here is acute sterile pancreatic fluid collections do not require any intervention in the first or second week or even third week of illness. This is case 2. A 20-year-old lady came with acute pancreatitis, and this time she showed 50% necrosis with fluid collections, classically acute necrotic collections. She had early organ failure, required ICU treatment, and improved, but again started having fever in the second week of illness. Now is the time when you actually start suspecting that this patient may be having infected pancreatic necrosis. Unfortunately, we do not have many tests to confirm our diagnosis. Most of the time, you have to depend on your clinical acumen, and some of the tests, for example, procalcitonin might be helpful. So this patient was started on enteral nutrition through NJ feeding, given a combination antibiotics, but fever continued, and she was found to have large necrotic collection. So in such patients, if they have acute necrotic collection which is likely infected, should we drain or not in the second and third week of illness? Now, this is a question which remains unanswered. We really do not have much data to suggest whether or not to drain. The guidelines so far suggest that invasive intervention, whether percutaneous, endoscopic, or surgical, wherever possible should be delayed until 4 weeks for the collections to become walled off. That's the guideline. However, there are patients in whom you may be forced to drain. And a pointer trial done by the Dutch group showed not much difference between early and late drainage. Early in their case was mean of 22 days after onset of illness, and late was 29 days after the onset of illness. Another study, which was a retrospective observational study from US, showed that early endoscopic drainage may actually be feasible, but these patients require more surgical necrosectomy, and we are actually, there's an ongoing RCT in this regard at AIMS. So coming back to this case, she had fever, TLC was 24,000, she had tachypnea, PaO2 FiO2 was initially 280, but then it worsened to 190. That means she had acute infected necrosis and there is worsening of organ failure. Now, this is the time when patient is not responding to your antibiotics. And if you have a fluid collection, we have to intervene. For example, this is a collection with some air inside like this, and you know it is likely to be infected necrosis. So this particular patient, for example, underwent a percutaneous drainage, and Acinetobacter was found, showed discharge after 6 weeks, improved with drainage and antibiotics alone. So this is the currently accepted paradigm that we should manage these patients conservatively. If that fails, go for percutaneous catheter drainage, and if that doesn't work, we go for minimally invasive necrosectomy. You can't really do any invasive necrosectomy in the second or third week of illness. And this is what we actually showed many years ago, that when we compared surgery with conservative treatment in patients with infected necrosis, because surgical necrosectomy was the norm at that time, we found mortality actually was somewhat lower in those patients who were managed primarily with conservative therapy. And again, we did a meta-analysis to show that about 64% patients improve with conservative first treatment, which includes percutaneous catheter drainage. 70% require catheter drainage. Necrosectomy was required in 26% with a mortality of 12%. Now, coming to another case, a young man came with acute necrotizing pancreatitis, 5th week of illness, and was running fever with increasing counts. Now, this is the classical case where you find in the 5th or 6th week of illness, you have a large collection in the lesser sac. And if you see here, it's a heterogeneous collection, suggesting that there is necrosis within it. And this is time when actually these patients require drainage, which can do it either endoscopically or minimally invasive surgery, which could be laparoscopic or sometimes ward. And we can either place a metal stent or a plastic stent. The general trend nowadays is to place a metal stent. It provides better drainage. And of course, there is a possibility of necrosectomy when you have such a patient who either has fever in the beginning itself or develops fever after you have drained the collection. So many times you have a sterile collection and you drain either with a plastic stent or with a metal stent, and you find that the collection has become infected now. So in such patients, the advantage of putting in a metal stent is that you can easily go and do endoscopic necrosectomy, although that is a possibility even in plastic stents. But here, the diameter is about 16 millimeter, and your upper GI endoscope, which is about 9 millimeter in size, can easily pass in through the metal stent, and larger chunks of necrotic material can be easily taken out. And many types of metal stents are available nowadays. They are slightly expensive, but I think overall, they provide very good drainage. And then this is how you can do necrosectomy in these patients. And 2 randomized trials have actually shown that both endoscopic therapy and laparoscopic or minimal invasive therapy are equally effective, but somewhat lesser complication with the endoscopic therapy. In fact, both these trials use 2 7 French plastic stent rather than a metal stent in the endoscopic arm, and thereby suggesting that even plastic stents are reasonably good enough for these. And these are the results. In fact, the mortality in these trials were very low. In the Dutch trial was 13 and 18%, and in the American trial, the Miser trial, was in fact less than 10%, which is quite remarkable to my mind. Now, this is another example of a 20-year-old patient who came with respiratory failure, or renal failure, first week of illness, improved with conservative therapy, 4th week of illness, started having fever, high TLC, and procalcitonin was 6. Less than 0.5 is less than 1 is normal. He had 6, and there was no improvement with antibiotics. Now, again, this is a patient with multiple large collections where endoscopic therapy or even surgical therapy would be rather difficult because patient had organ failure and just about improving in the ICU. So this is what I showed earlier, but this is not the case. Most of the time, you may find a large collection away from the stomach and duodenum with air inside. So these patients are ideally managed with percutaneous drainage, as I showed you earlier. And per-oral necrosectomy is difficult. But if the patient doesn't improve, what do you do at that time? Because per-oral necrosectomy is not possible. Then you go for minimally invasive necrosectomy, which could either be endoscopic or surgical. Surgical is ward or some similar technique. So what we do is a percutaneous endoscopic necrosectomy. We place a percutaneous drain, initially 12 or 16 French, and go with a very ultra thin endoscope through the same tract and do lavage, which helps clear the pus, and these patients have improvement. And after you have dilated the tract about 12 millimeter, you take your normal upper GI endoscope and do lavage and necrosectomy. One of the patients, this slide is my favorite slide, which I've shown in multiple my presentations. Patient in the ICU, multiple catheters there, and you do bedside endoscopic lavage or sometimes even necrosectomy. You see here the tract is being dilated to about 12 millimeter with a balloon. Go inside with your regular upper GI endoscope. Make sure you do not inflate this with too much of air. We generally use carbon dioxide. Don't inflate too much of air, and very gently, gradually remove the necrotic debris. You don't have to remove debris in the first sitting. We take at least 3 to 4 sittings to take out the necrotic debris. More important is lavage and sucking out of all the pus which is inside. And after you've done that, and this will again take 2-3 sittings, then you find the cavity becomes very clean, and patient will improve subsequently. And this is how you take out necrotic debris. They're not large pieces. People are, very fancy to show nowadays large pieces, but most time you don't get large pieces. And this is how the cavity may look like. We published our initial experience in 2015. Subsequently, we became a little bolder. You find large collection in the paracolic area going right up to the pelvis here. And one of our assistant professor, Dr. Soumya Jagannath, did this. Multiple catheters have been placed here. Patient didn't improve. You can see with the endoscopic picture, large necrotic debris here. And so sometimes what we do now is to place a metal stent. Soumya is actually quite interested in placing metal stent percutaneously and then doing necrosectomy. You see the entire cavity has been cleaned up with this. And this is the follow-up MRI, which showed complete resolution of the collection. This is our latest experience. 177 patients with acute necrotizing pancreatitis were treated with percutaneous endoscopic step-up therapy and with an 80% success rate. So very important to realize that location, number, timing of PFCs and organ failure determine the outcome, and they also determine the type of therapy that we can employ in these patients. Again, I just want to show that when we read a trial, we say, oh, this therapy is going to be the best. So this is the MISA trial. 168 patients were assessed for eligibility and only 66 were analyzed. Mind you, tension trial had 418 patients were analyzed, only 98 were included. That means a large majority of patients will not fit in those criteria which were used during those RCT. I'd like to just finish up by the last case of a 35-year-old male presented with abdominal pain and distension 3 months after the illness. So this is not acute, this is rather subacute or towards chronic. He had a large pseudocyst. And again, I want to emphasize that we have to differentiate between a pseudocyst and a wall depth necrosis. And here the treatment again is either endoscopic or laparoscopic. We did a randomized trial, which was published about 3 years ago, and we showed both are similar in terms of outcomes, but necrosectomy was required in a larger number of patients with endoscopy because we use plastic stent, and many of these patients actually developed fever after the drainage. About 60% develop fever, and 12 of these 18 patients require repeat endoscopic drainage and necrosectomy. Then we did another trial where we compared metal stent versus laparoscopic drainage in those who had larger amount of debris. And we found, again, both techniques were similar in terms of success and need for additional therapy. But in terms of hospitalization and duration of illness, duration of procedure, endoscopic therapy was better. So ladies and gentlemen, I'd like to summarize by saying that acute fluid collections without necrosis mostly resolve. Those who have necrosis, it is necrosis which determines the outcome of the fluid collections. In acute sterile pancreatic fluid collections, no intervention is required. In large majority of cases, if we have infected necrosis, we do a step-up therapy with conservative first, followed by endoscopic or percutaneous drainage, and followed by minimally invasive necrosectomy. Mind you, in suitable patients, you may straight away go for endoscopic drainage rather than percutaneous drainage. And if you have a walled off necrosis which is symptomatic, we can do either endoscopic or laparoscopic drainage. Thank you very much for your kind attention. I'll stop here.
Thank you, Dr. Pramod. That was very nice, as usual. So you have shown several cases with a different degree of severity and how they were managed. May I request the panelists to have any questions or comments to share it? Shaukat, Dr. Suraj, Dr. Arun.
Garg sir, a very good evening. Sir, one edition is like before we used to do lavage by pushing with the syringe from.
Not
what
able
is it
to hear you well. I'm unable to hear you.
Yeah, I think there's some connectivity issue.
Can you just repeat the question?
Still not audible?
It's breaking in between.
Or
you can type in the chat box as well. We can read it out for you then. Meanwhile, somebody else has a question or comment. Dr. Aka?
Yeah, hi. Hello, Dr. Pramod. Excellent talk as usual. And excellent work. I think needing less and less surgeons for managing these cases. So really fascinated to see your experience. So I think nothing really to ask you about. Thank you.
I have a number of questions.
Okay, Dr. Subhash.
First of all, when we used to do, nowadays I'm lucky I don't have to do it, we used to have a lot of bleeding complications. And that was usually used to be the sort of, hairy or a scary moment for us. Second question, we used to use a lot of retroperitoneal flank approach. And I used to find that really excellent in draining, at least in one of the presentations, which Dr. Pramod showed, a small leak at the retroperitoneum but drained everything out, rather than expensive sort of endoscopic, in the one which was kind of bulging in the flank. But that somehow has not received as much attention as it should. But I think that's really rather than focus, we've been completely on laparoscopic and endoscopic, but a flank incision, and that unfortunately has not received as much attention as it should. And finally, one of the problems that we've had is sometimes we end up with a gastric fistula and we find it very difficult to feed them. And what do you do in such situations?
Thank you, Subhash. So you have raised all very, very pertinent points, and the reason I didn't dwell upon them was, if you get into these things, you can't complete your talk. So thank you for asking these questions. So bleed again, of course, is a very important. In fact, we recently analyzed our 400 patients with large collections, and we found bleeding was a major problem in about 9% of these cases. In fact, the bleeding which is often due to either a pseudoaneurysm or bleed from the wall of the fluid collection. That complicates the whole thing and then becomes very difficult to do any kind of minimally invasive therapy. Fortunately, if we are able to find or recognize a pseudoaneurysm, it is easy. You do embolization and geographic embolization and then going the way you used to manage. But sometimes it has so happened that we were not able to control the bleeding, or we didn't find the source of bleeding, and these patients ended up having a surgical procedure. Even during surgery, and as you very well know, it is often difficult to identify the bleeder or control it. So bleeding, I agree with you, there's a major problem. In fact, if you put large percutaneous drains, that itself may also be a factor that we have recently found as one of the causes of bleeding in these patients. The second point you mentioned about retroperitoneal approach, and I again agree with you. If you have a large collection which is bulging in the flanks, and you find on CT or MR there is a significant amount of necrotic debris, I would be happy if the surgeons takes up this patient, gives a small incision. And this is what classical board was. They used to make the 5 centimeter incision and then take out all the pus under guidance. And I think that's a very, very good procedure. Third is about gastric fistula. Some of the other gastric fistula, we haven't had a major problem, except in occasional patients. So when you do this endoscopic drainage, put in a metal stent, if it is in the lesser sac, it drains out everything. You take out the metal stent, put a plastic stent, and I don't find any patient having a gastric fistula. What has sometimes happened is that you have done endoscopic drainage, created a fistula, and you also have a percutaneous drain there. You know, but these patients require multiple catheters. And then we have seen that this percutaneous drain is draining gastric content. That becomes a fistula. Yeah. But for that, we are nowadays able to manage it. I mean, gradually you downsize the catheter and they do well.
So I just brought that up because recently we had a similar situation, and we actually fed him from the PTBD side because we could not feed him from the sort of nasogastro-NGJ tube. And that worked quite well, actually. And we were able to feed him from the biliary. There's a biliary pancreatitis. And so we had, for the jaundice, we placed PTBD. We advanced as they improved. Was all what we were giving him through the NG tube was draining out from the drain sites, as you rightly said. Thank you very much. Really enjoyed this. And any questions from the panel?
I have one question.
Yes, Shaukat, go ahead, please.
Yeah. As usual, very nice, crisp and lucid presentation, Pramod sir. My question is that most of acute severe pancreatitis patients have pancreatic duct disruption, and so are the local complications. The question is that, can we evaluate for pancreatic duct disruption early by an ERCP? How safe is that? Did anybody try that? Is the question.
So important question, but short answer is it is not a real major problem. And Sandeep can dwell on that a little more detail. He has recently published a good paper in gut. So majority of patients who have large necrotic area involving the body of the pancreas would have a disconnected pancreatic duct. Okay. And that is why in these patients, you need to place a plastic stent for 4 to 6 months. Fortunately, in majority of these patients, the fistula, the ducts get strictured and there is no more fistula. You can safely remove the stent. And in only 5 to 10% of cases, there could be either a recurrence of a fluid collection or sometimes large collection, which may require re-drainage. We don't do ERCP. Most people don't do ERCP to assess for this because it is likely to be there. Sandeep, if you'd like to add to that, you may do so, please.
As you rightly said, the necrosis of the pancreas also causes necrosis of the duct. And this disruption, once you drain off the collection, heals also with scarring. And this scarring causes a disconnection of the upstream pancreas from the downstream pancreas in the head. So when we remove the stent, if you have a reasonable size cavity, we were actually placing plastic stent at that time. And we did a randomized kind of a study where in one arm we did a plastic stent, other arm we did not do anything. And we found that there is no difference in the either arm, which means that both groups, whether you place a plastic or don't place a plastic stent in the residual cavity, can have with a disconnected duct proven anatomically on MRCP, the recurrence of collection is equal in both the arms, which ends up saying that there's no point putting any more plastic stent. And those patients who have a disconnection and come with a recurrence of symptoms, which is less than 10%, if they have a small recurrence of pancreatic pseudocyst now, it will not be a necrotic pancreatitis, it will be a pseudocyst. You can do an EOS and place a plastic stent and leave it permanently. So this is now the the common path that we follow in most patients. If we have plastic stent, we can discuss about that permanently, but if you place a metal stent, we have to remove after a finite indwell time of 3 to 4 months, 3 to 4 weeks, and then no plastic stent is required in such situation.
Yeah, Sandeep, can I ask a question, Dr. Pramod?
Please.
Yes, Dr. Arora.
Thank you, Pramod. Excellent as usual, brilliant as usual. We have two stalwarts of surgery, Dr. Anil Agarwal and Dr. Subhash. And in your whole algorithm, there is no role of open surgery. Is that the order of the day? That is option number one?
No, not at all. In fact, many of our patients require surgery. About, in every year, I think at least 15-20% of patients require surgery for various things. And this could be because of incomplete drainage, incomplete control of the source, and bleeding complications, fistula, bowel fistula. There are many things. And surgery is very much there. In fact, right from the beginning, second, third week, our patients are regularly seen by surgeons. So surgery is very much in. And as I said, earlier also, those with large collections, large necrotic debris will benefit from surgery. Yes, Dr. Agarwal.
I think I was going to ask the same thing, that in your protocol, when do you refer it to the surgeon or the radiologist? Looks like 15-20% you let the surgeon survive.
So
what's your protocol for referring patients for these?
So protocol is very much step up. I mean, hardly any patient would directly go for surgery. Although, as I showed, that those who have proper walled-off necrosis with either sterile or infected, laparoscopic drainage internally is excellent. In fact, those who have biliary pancreatitis, we prefer laparoscopic drainage.
In fact, one of your cases, I thought was a very good case for laparoscopic or minimal invasive drainage, but probably you manage them.
No, absolutely. So I showed you two randomized trials that we performed, and both showed similar results. Laparoscopy, to my mind, is an excellent procedure, particularly those who require cholecystectomy as well. The only issue is those who do not have walled-off necrosis. You have multiple large collections, not properly walled off. You have necrotic debris. Patient is sick. He's having organ failure. That's my problem. Those who do not have organ failure, I'm fine. The problem with those with organ failure in ICU, surgery becomes very difficult.
Yeah, Pramod, in setup like ours, most of the patients are referred to us right on day one when they have raised serum creatinine, they have AKI, they require respiratory support. Otherwise, they are not referred to the tertiary center. And this is the subgroup of the patient in which we may say it is too early to intervene or too late because nothing can be done. The results of the surgery are pretty bad in the sense that you have a 70% mortality. Ultimately, we have to bank upon Arun Gupta more often than not to drain it, to bring it to a semblance of doing something in which you have a wishy-washy algorithm which you have shown. Most of the time, these are, violent and wild collection rather than WOPN. Arun, you like to comment?
Definitely, this is a major problem, and early patients, all our even drainages, because of if they are necrotic, it becomes difficult to drain, and this is definitely a problem we see. I also want to make two comments besides this point regarding regarding the surgery for a well-defined collection, putting a nick on the flank. I would say the problem is the pancreatic fistulas. It's very easy to drain them, but ultimately they lead to the pancreatic fistula, and then the management becomes more difficult. And another is that the discussion about the fistula. So the proper selection of patients who require endoscopic drainage in the form of putting metal stent and doing lavage is of utmost importance. Otherwise, many of the patients ultimately land up with this situation where we, even after putting the metal stents and doing the endoscopic therapies, we have to place a stent, and then it becomes the gastric fistula.
Okay, let me throw some questions from the audience. Dr. Pramod Garg. I think Tahir Mahajir has asked, what is the role of anticoagulants in patients who have splenic vein thrombosis due to acute pancreatitis?
So again, an important point, about 10% of patients may develop splenic portal vein thrombosis, more often splenic vein thrombosis. there are no data to suggest that we should give it prophylactically or even therapeutically. So, and they really do, overall, they do well in the long run also. But I think there is a case for a randomized trial where you can start anticoagulants in this subgroup of patients, see how do they behave. But as of today, we do not have any guidance whether or not to give. So generally, we don't give, except those patients who are in ICU are prolonged immobilization. Then, as the protocol in ICU is, we give them prophylactic Clexane OD.
Thank you. There's two more questions from Pankaj Navgare, who's asking a role of octreotide and role of enteral nutrition in pancreatic fluid collection.
So again, for octreotide, there is no proven role, and we don't use it, except sometimes we have tried in those patients who have got either a pancreatic fistula or a pancreatic ascites, and we place a nasojejunal tube and give them octreotide and see whether it helps them or not. Other than that, there is not much role. With regard to enteral nutrition, of course, this is a very, very critical point. Such patients must be given enteral nutrition, and often those with moderate to severe pancreatitis require enteral tube feeding rather than oral feeding. And I think putting in an early nasojejunal tube is of very, very high importance in these patients.
I'm glad that point has been answered, because nutrition is the most important treatment. And by end of first week, you know that this patient has severe pancreatitis and is going to have a prolonged course. And those are the ones where NJ tube has to be placed.
Am I audible now?
Yes, Suraj, please go ahead.
Garg sir, while using hot Exios, would you like to use over the guide wire technique or straight away?
So generally we use straight away. We don't generally use a guide wire, and most people now are comfortable using a direct puncture rather than over the guide wire.
And one quick addition, while doing lavas, sir, are you using water jet nowadays or not?
So yes, so we generally use, with the 50 ml syringe, you flush it well, or sometimes you use a water jet, but the water jet that is available doesn't have a very high pressure. And I think 50 ml syringe is good enough for that.
Dr. Sandeep, Dr. DK Singh had a question.
Yes, sir.
You had a comment.
I just wanted to know, with the peripancreatic fluid collection is less at the 4 week, and a pleural left-sided pleural fluid collection is much more. How best to manage?
No, I'm not sure I understood it correctly. You're saying if there is a significant
pleural fluid collection with raised amylase is much more than the peripancreatic fluid collection.
So any pleural effusion which is significant must be drained, regardless whether it is more or less than the abdominal collection. So in fact, some of the pulmonologists are quite aggressive in this. They say even if you have 300, 400 ml of fluid, you must take it out. So my suggestion is to put a 8 French pigtail drainage if any patient has significant pleural effusion. It really helps them in their overall respiratory function.
Dr. Arora, is there any question from your side? Or are we having time?
I think, we have 1 minute.
I think, okay.
Can I ask a question to, why is it, you say any surgery is the sine qua non for everything? Why is it Subhash and Anil that surgery has to be done repeatedly, it has dismal results? Why can't we remove all the necrosis in one go? Why do we have to go in repeatedly?
Is a question for me or Dr. Anil?
Yeah, both.
Yes, Subhash, go ahead.
Yeah.
So, the hesitancy in answering the question gives you the answer.
No.
Not exactly, Dr. Pramod. Just wait for the answer.
I think clearly there is, there was a time when, of course, everyone used to say that surgery has to be done immediately, the beggar's days. And then subsequently the pendulum swung too much to the other, that surgery should not be done. I think in between there is a happy ground, and which Dr. Pramod has rightly placed, that the first week perhaps nothing, second week also nothing, and thereon afterwards, I think all the methods, some of the interventions that you showed could easily have been done surgically. But I think surgery has gained a poor name because First of all, most surgeons are not complete sort of physicians, and they need these patients need intensive care inputs. They need sort of multiple inputs from physicians. And perhaps if there were a unit which dealt with all of this collectively, then it would be much easier. Otherwise, I think surgery has gone into disrepute mainly because initial surgeons were very aggressive and they didn't have a sort of a combined approach as you see nowadays with the endoscopist, interventional radiologist, and the intensive care person.
Can I add on to that, Dr. Pramod? The issue is that, I mean, earlier on also it was planned second surgery because I think the right time to go in is when the necrosis is separated. So it is the third. Sorry, is that from my?
Somebody has logged in from 2 devices. Can you check up the organizers, please?
Dr. Suraj, can you mute? I think it's coming from you. Dr. Suraj, can you mute yourself?
So the issue was that third, fourth week when you go in, and because you only remove the necrosis which is separated, because the necrosis which is not separated. So that is why earlier on it was that you do a planned second surgery. And the second thing that, so that is why some of those patients, and for that reason, they used to do the lavage after putting 2 big bore drains at the time of first surgery. And of course, then it was changed by the step-up approach. And Subhash, I would not say that it is really into disrepute because the patients which are referred after everything else has failed. And then if you want to compare that morbidity and mortality with the cases that you have got, I mean, that is not a fair point to do because I think that some of the slides that you showed, it was a well-separated necrosis, I think, in which we went with the endoscope. I mean, you were just flushing it out, and that is, I mean, you would credit the surgeon with that much that obviously what all is separated, he would remove them during surgery. And a lot of times it is major big chunks which are there. And I think some of this necrosis which is not separated, we are not taking it out. And also sometimes you have to be careful about the bleed which may occur at that time. So I think when you do a blind thing also in some of the areas, you see to it that the strands you don't disrupt because those are sometimes the vessels which have been left behind by the necrosis.
So let me just add one point, and to be fair to surgeon, and you see, we should understand that these patients have so much of inflammation and sometimes adhesions. It is very difficult for surgeon to actually go dissect out and take out the necrotic debris. We think the surgeon will open up and clear out everything. That's not the case here. And there are so much chances of collateral damage to bowel and blood vessels. So surgically, I think it is very difficult for surgeons to go in early. You see, if you give them a case after 4 weeks or 6 weeks or 8 weeks, they will do a wonderful job. So in the first 2, 3, 4 weeks, nobody can do much. And that is why people rely on these percutaneous minimally invasive catheters to buy time so that sepsis gets controlled to a large extent before you do anything. And again, we agree with Dr. Agarwal that often patients who are referred to surgeons are the worst kinds. They have failed everything, their albumin is down, they have secondary organ failure, their nutrition is poor, and they have resistant infections. So I think it's very difficult to say what is the right time for patients to go for surgery.
As we jokingly say, it's child's D and not child's C.
Right.
So the bottom line is
When
that
it reaches the
when we have severe acute pancreatitis, I think it's best to involve the intervention radiologists and surgeons right from the word go.
Absolutely.
Just to have a team and then work around it. You can work as 2 ways of draining, like percutaneous and endoscopic, or surgical and endoscopic. And that's the best way, along with nutrition and intensivist. It's a team effort. Single, I think nobody can take care of all kinds of pancreatitis. I think with that, we can probably sum up here and move to the next session. Thank you very much, ladies and gentlemen.
Just short answer will be needed. Do you think that over the years, the mortality and morbidity is decreased of severe acute necrotizing pancreatitis? Because in my days in Gangaram, it used to be terrible.
So answer is, in early persistent organ failure, the mortality has not decreased. It has decreased to some extent, marginal extent. And I showed you those 3 large series, up to 40% mortality all over the world. But mortality for the late phase, infected necrosis, that has decreased. We are below 20% actually now, and our wish is to reach below 10%, single digit. That's the answer.
Dr. Pramod, can I just add on to that? Just one word, as you rightly said, it is the search related and the early, which is not related to the necrosome. That mortality has not decreased. However, infected pancreatic necrosis related morbidity and mortality because of the step-up approach has drastically decreased, and it is now in very manageable kind of limits. Thank you. And thanks for giving 15 to 20% cases for surgeon to survive. Thank you.
But Pramod, it is not easy to separate the two. It is a very group of the patient who had an early mortality, early organ dysfunction because of SARS. They are more likely to go to the infected pancreatic necrosis. It is
absolutely
all coupled.
Right.
At the end of the day, I agree with Subhash. It has not changed.
Right, sir.
Okay. Yeah.
Thank you, Dr. Subhash and Dr. Sandeep, for this exciting discussion. Now we'll have to move to the next session. That is the session on Diagnostic Eos for beginners. For this, I would like to invite our moderators, Dr. Malay Sharma and Dr. Saransh Jain. Dr. Malay Sharma is a very senior gastroenterologist from Meerut as well as JP Hospital, Noida. Dr. Saransh Jain, who has been trained in gastroenterology from AIMS, is a consultant at Astha Hospital, Ahmedabad. So over to you, Dr. Malay Sharma and Saransh, for inviting the speakers and the panelists.
Thank you so much, sir, for the kind invite. And it's an honor, sir, to be here moderating this session with the stalwarts of US, Dr. Malay Sharma. And I would like to invite our speaker, Dr. Surendra Rana. He has been the pioneer of US in India and is a professor of gastroenterology in PGI Chandigarh. And what best to learn as Diagnostic Eos for beginners by such a great knowledgeable person as Dr. Rana. Sir, please.
Good evening, everyone. Am I audible?
Yeah.
So I'll just share my screen. Are the slides visible?
Yeah, they are visible.
Good evening, everyone. At the outset, I would like to thank Dr. Anil Arora and team Sir Gangaram Hospital for inviting me and giving me an opportunity to participate in these clinics, which are quite popular with gastroenterologists in our country. So I have been asked by Sir to speak on Diagnostic Eos for beginners made easy. At the outset, I thought it's a pretty tough topic, and it's very, very tough job to make an EOS look easy, because EOS requires cognitive and technical skill set, which requires combining endoscopic manipulation and ultrasonographic interpretation. So actually you require two different skills to be a good endosonologist. And hence there is no magic wand to make an EOS look easy. A systematic approach and training, however, can make it look easy. So if you look at how to acquire competence, this is how most of the procedures in which competence is acquired flows through this pyramid. First is to acquire a knowledge, then knowledge of how to do the procedure, then do the procedure under supervision, and finally do the procedure on your own. That's how you acquire a competence in any of the procedure in the medical sciences, and same holds true for endoscopic ultrasound. So first question is knowing the procedure. So you need to have a theoretical knowledge, which is basis for proceeding to training on simulators and supervised clinical training. So you need to have an anatomical as well as theoretical knowledge of endosonography, which you require to know about the indications, the contraindications, which can be learned from textbooks, scientific journals, and short-term courses, which are held along with various conferences. And this acquired knowledge should be tested using a validated theoretical exam. And most of the centers where fellowship is done, they use validation tests based on multiple choice questions. So once you acquire the knowledge, then is to know how to do it under supervision. So in this era of patient safety, a simulation-based training is required. So hence it is no longer acceptable to put the burden of initial training on patients, as patient safety is of paramount. So now the current trend is that the initial steep part of the learning curve should be overcome using simulators. And fortunately for EOS, we have a lot of simulators, which can be rubber models, animal organs, live anesthetized animals, and then virtual reality simulators. So once you have acquired a sufficient knowledge, then you should do a supervised performance on patients, because we need to understand that all the aspects of the procedure which are practiced on simulators are not 100% realistic. So one need to perform initial endosonography procedures under supervision. So self-learning of EOS should be discouraged, and the number of supervised procedures which are necessary to acquire competence varies from trainee to trainee, center to center, as well as procedure to procedure. So we need to have our own set of number of procedures which we need to do our trainees to perform to acquire competence in EOS. So hence, these 3-4 slides re-emphasize the fact that to achieve a certain level of competency, additional training is required, with numerous studies which have demonstrated importance of learning curve in improving the EOS accuracy. So because of this, in 20 minutes, I must admit it's very, very difficult to make EOS easy. But in this talk of 20 minutes, I'll just briefly talk about the tips and tricks of performing a diagnostic EOS briefly. There are many techniques and maneuvers which you can read through textbooks to perform a diagnostic EOS. I'm not going to go into the details of all of those techniques and maneuvers, but I'll probably discuss the easiest ones so that for the beginners, it looks to be a little easier and they can follow what can be done easily. And finally, I will also discuss few common mistakes which are done by beginners in performing EOS. So if we look at diagnostic EOS, it has 2 broad components. One is correct image acquisition and interpretation. And second part is tissue acquisition, which is the workhorse of EOS, which includes fine needle aspiration or a fine needle biopsy. Now, whenever you start doing an EOS, as it is true for any intervention, the safety of the patient is first, and the beginners should know that echoendoscopes are different from the gastroscopes and duodenoscopes, which they have been trained for endoscopy because of relatively tougher insertion tube and the longer bending section of the endoscope, and the radial echoendoscope of few of the companies have an oblique viewing. So that also need to be kept in mind by performing an endoscopic ultrasound. We need to know that there are relatively blind areas of intubation, which includes the cricopharynx, the D1, D2 junction, the rectosigmoid one is doing a lower GI EUS, and also across the strictures. So these are the areas where the risk of perforation is very, very high. So one has to be very, very careful while intubating these areas with an echoendoscope. And these echoendoscopes have a tougher and a longer bending section. So this leads on to higher chances of perforation if the procedure is not performed carefully. Now, once you go onto the machine, you should know where is the right, left, anterior, and posterior on the EOS screen if you are using a radial scope. And if you are using a linear scope, you should know where is your cranial, the caudal, anterior, and posterior. So all anatomy is described on these 4 parameters. And as an endoscopist, it is very, very important to know where is the tip of the transducer, because as an endoscopist, we are reflexively trained to move up and down wheel of the endoscope. So that the tip of the echoendoscope where the transducer is will be in very abnormal positions, and it will be very, very difficult for you to interpret the anatomy. So hence, very little movements of the tip have to be done so that the image remains stable and you can clearly identify the structures. So knowledge of anatomy is a must. So as surgeons learn the knowledge of anatomy to perform surgery in a better way, same as an endoscopist who want to learn endosono, they need to have a thorough knowledge of cross-sectional anatomy of the esophagus, mediastinum, as well as the abdomen. And we need to also understand the fact that all these structures may not be visible in one frame. I have seen beginners struggling to get all these structures in one frame. So they try to get a stack sign, they try to get a bile duct, portal vein, pancreatic duct in all one frame. It is not possible in all patients. So one should be little patient, and little right-left movements can bring the structures which we need to study. We also need to remember important fact that the structures which are parallel to the ultrasound beam will appear longitudinal, and the structures which are perpendicular to the ultrasound beam will appear circular. So that's why the anatomy on the radial and linear echoendoscope are different based upon this principle of physics of ultrasound. And then we also need to know that the mediastinal EUS is the easiest and the pancreaticobiliary EUS is the most difficult because of lot of anatomical structures stacked together in the pancreaticobiliary region. So acquisition of images and interpreting the images becomes a little difficult. So once you start doing an EUS, at each point of examination, what we call as a station approach, you go to each station, you need to identify one vascular structure which serves as your home base, and this will help in reconstructing the anatomy. And then the spleen anatomy, it should be, because in the linear echoendoscope, the cranial end can be flipped onto right or left. So you should keep the screen anatomy as you are comfortable and as you are trained on. And many people use balloon. So balloon should be inflated sufficiently enough to displace any intraluminal air, and the transducer itself should be placed roughly in the center of balloon. Many times doing an EUS, I have seen the balloons have been placed asymmetrically and the transducer is not in the center of balloon. That makes image acquisition little difficult with EUS. So as the linear EUS is most commonly performed, and it is an EUS which is required to do an intervention. So in this talk, I'm going to briefly talk about how to acquire good EUS images and briefly talk about the linear EUS anatomy. So linear EUS as compared to radial EUS is more time consuming and tedious. It is therefore critical to adopt a systematic approach in image acquisition, especially for the beginners. And the first step is to locate where the cranial end is. So as I was talking about, the cranial end can be on the left-hand side of the screen or the right-hand of the screen. This H, which is denoted, denotes the cranial end of the transducer. So accordingly, you should adjust your image the way you have been trained to acquire the linear EUS images. The most critical thing in linear EUS is two steps. One is gradual withdrawal, and second is 360-degree rotation, so that you acquire the images all around the structure which is being imaged. So the withdrawal can be 1 to 4 centimeter. In case you are looking for lymph nodes or smaller structures, then the withdrawal has to be less, about 1 centimeter, and then you rotate 360 degrees. My preference is 180-degree right and 180-degree left, so that you get a 360-degree rotation, and then you scan all the images, all the structures around the transducer. So with the rotation of scope, these are very, very important two facts which we need to remember. Once your transducer is facing ventrally, if you rotate to the right, then the transducer also moves to the right side of the body. And if your transducer is directly to the dorsal of the body, then the rotation to the right of the body of your body moves the transducer to the left side of the body of the patient. So these are the two most important critical facts which we need to remember while we are performing a linear EUS, that if your transducer is facing ventrally, the movement of the transducer will be on the same side as you move the body of, as you move your body. And if the transducer is directed dorsally, the movement will be on the opposite side. So for mediastinum, the starting point is aorta, that will serve as your base station, which appear as a linear anechoic structures. So many of us would have seen this while the EUS is being done. And then you rotate the echoendoscope 180-degree in clockwise, return back to the neutral position, and then rotate 180-degree in counterclockwise direction, so that you have done a 360-degree evaluation of the structures around the esophagus. And then, as I've highlighted already, this needs to be done initially at the first step, and then with a gradual withdrawal repeated after withdrawing every 1 to 2 centimeter. It is very, very critical to remember that it has to be withdrawal and not insertion, because blind insertion without an endoscopic view can lead on to perforations. So at the GE junction, you identify the celiac axis and superior mesenteric artery, which are arising from the aorta, with celiac axis being cranial to the superior mesenteric artery. This is the classical view. And then you rotate the shaft of echoendoscope to the right. This will bring sequentially left lung, right atrium, right lung, azygous vein, and spine. So these all you can read from textbooks of anatomy and EUS, what anatomy is coming. But the most important critical steps which I've highlighted is gradual withdrawal and 360-degree rotation. So this is how the aorta and azygous vein will appear on rotation to the left and right respectively. And then you gradually withdraw and you see the left atrium, the right pulmonary artery, where you see the subcarina and you see the lymph nodes. These are the common areas for which the patients are referred to us for sampling of the subcarinal lymph nodes. And little withdrawal and turn to the left, you will get the aortopulmonary window, which lies between the arch of aorta and the left pulmonary artery. So these are the common structures which are seen in mediastinum. And similarly, in the upper abdomen, there are a few important facts to remember. that the stomach is a mobile organ and it is stretchable. So stretching of the stomach with an echoendoscope will lead on to variation of its relationship with surrounding organs. So insufflate no air in stomach, completely suck all the air so the stomach is decompressed. And then you identify the major landmarks or home base, which is abdominal aorta and the mesenteric vessels. It is also important to remember that if the patient has hiatal hernia, especially the elderly, they have a large hiatal hernia, visualization of abdominal aorta and the mesenteric and celiac artery becomes difficult. So one should not be struggling in that situation. One can do a gastroscopy and see if there is a large hiatal hernia. Then we need to understand the limitations of performing an EUS from the GE junction in these patients. And once aorta is identified, then echoendoscopy is advanced slightly, celiac trunk is identified. Once you identify the celiac trunk like this, so this is the crux of the diaphragm, the celiac artery, the superior mesenteric artery, and then you just rotate your the echoendoscope to right, so you will see the left adrenal gland, which appears as a seagull sign. And then from this position, the leftward rotation will bring the left lobe of liver, and advancing 1 to 2 centimeters farther will image the superior mesenteric artery coming from the aorta. So between the celiac artery and the superior mesenteric artery lies the body of pancreas, and pancreas is one of the most common organs for which EUS is performed by us. On a linear echoendoscope, the pancreas appears in cross-section with pancreatic duct appearing as a small equilucent circle, and then the echoendoscope is rotated to right to view the distal pancreas, left kidney and spleen, and you rotate to left to view the neck of the pancreas and genu. So this is how pictorially the same appears. You see this left adrenal as a seagull appearance. This is how pancreas appears on cross-section on a linear EUS with a dot-like pancreatic duct, and you will see two vessels, splenic vein and splenic artery. The artery is thick-walled, smaller in caliber as compared to vein, which has got a thinner wall and is larger in caliber. And then you cross the scope into the duodenal bulb. This is an area where you see the pancreatico-biliary structures. So gentle downward deflection is applied to the tip of endoscope so that you fix the endoscope at apex. And once the apex is visualized, you start seeing the bile duct, the portal vein, and the pancreatic duct. And finally, the last step is to go into the second part of duodenum to identify the uncinate and head of pancreas. So you identify the ampulla of Vater endoscopically, place the transducer there. So you will identify the superior mesenteric vessels, the inferior vena cava, and aorta by respective left and right rotations. And from this position, if you slightly withdraw the scope, you will reach the ampulla to view the common bile duct and pancreatic duct running parallel. So if you rotate your scope at this position to left, you will see the bile duct. And if you rotate to the right, you will see the pancreatic duct. So pancreatico-biliary EUS is one of the most important indications of EUS, and for beginners, it is better to adopt a 3-station approach in which you first, in the G junction, look at the neck, body, and tail of pancreas, look at the abdominal aorta with the celiac axis, the portal confluence and the splenic vein and artery, the left kidney, the spleen, and the left lobe of liver. So all of these can be visualized from the G junction. From the duodenal bulb, that is the second station, you evaluate the portal vein, the bile duct, and the head of pancreas. And finally, from the second part of duodenum and sometimes in third part of duodenum, you can completely evaluate the uncinate process of pancreas, the ampulla, the convergence of the bile duct and the pancreatic duct, all can be visualized from second part of duodenum. So for beginners, it is very, very critical to adopt this 3-station approach to completely evaluate the pancreas. And once a sufficient expertise is acquired, then one can directly focus on the region of interest directly, or one can insert an echoendoscope directly to D3 and slowly withdraw into stomach so that the pancreas can be traced sequentially in its entirety from the uncinate process to the tail of the pancreas. Now, after discussing briefly about the various ways of doing a diagnostic EUS, I will just like to highlight few common mistakes which are done by beginners in performing a diagnostic EUS. First is failure to recognize the variations in pancreatico-biliary anatomy. It is important to remember that increased echogenicity, which is seen in pancreatic parenchyma, is not synonymous with pancreatitis. It is quite commonly seen in normal patients and can be mistaken for chronic pancreatitis by beginners. Similarly, hyperechoic pancreatic changes are frequently encountered in elderly, obese, and alcoholic patients. So they do not suggest presence of chronic pancreatitis. So if there is no parenchymal calcification and there is a normal pancreatic duct, even in presence of these features, you can confidently exclude chronic pancreatitis. Another important variation to recognize is that the ventral enlarge of the uncinate process of pancreas is oftenly hypoechoic, and I have seen beginners reporting it as a mass in the head of pancreas. So absence of a clear margins and a non-dilated common bile duct and a pancreatic duct helps in differentiating a ventral enlarge of uncinate process from a hypoechoic mass. If there is a doubt, either an experienced endosonologist should take over, or one can perform a contrast enhanced endoscopic ultrasound to differentiate between these two pathologies. Then about the variations in the ampulla and presence of periampullary diverticulum, we know that EOS is the gold standard for diagnosis of bile duct stones, but presence of a periampullary diverticulum will complicate, especially if it is large and the diverticulum is filled with debris. So intradiverticular papilla can also confuse because of the air artifacts that can produce a false stone-like image. So in case a duodenum, a periampullary diverticulum is seen on endoscopic image, it is better to fill with the duodenum with water, give an anti-motility drug like Buscopan, and then perform an EOS so that the papilla is submerged in water and free of air bubbles to avoid this issue. Finally, you should also remember that there are certain situations where one scope is better than the other scope. Especially, I would like to highlight the imaging of hepatic hilum, which is not considered by endosonologists. In case you want to explore the hepatic hilum, it is better to use a linear scope as compared to radial echoendoscope, because studies have shown that the hepatic hilum can be examined in totality by more endosonologists by using a linear echoendoscope rather than a radial echoendoscope. And similarly, a pancreatic tail, which is quite distant from the gastric wall, and using a radial echoendoscope, sometimes the tail cannot be completely examined. In these situations, it is better to use a linear echoendoscope to examine the pancreatic tail, especially if we are considering a possibility of smaller neuroendocrine tumors. And finally, for staging of early tumors, I would say that radial echoendoscope is probably better than linear echoendoscope for evaluation of early tumors for staging. Then we should also not forget that EOS can also help in evaluating the bile duct strictures. It is one of the common indications which is not considered by endosonologists for evaluation. So strictures which are situated 2 centimeters below the hilum, EOS with or without FNA, followed by ERCP with biopsy samples, is considered as standard of care. And if you have to remember, if there is a biliary obstruction proximally, EOS guided sampling should not be performed only if the patient is not a candidate for liver transplantation and a palliative intervention is considered. One can do a EOS guided sampling. And last thing which one has to remember is that EOS morphology alone is unreliable to identify response to neoadjuvant chemotherapy. So in case a patient has received a neoadjuvant therapy, you need to do a tissue acquisition to confirm recurrence of malignancy or a residual malignancy from post radiotherapy changes. So lastly, few slides about tissue acquisition. We all are aware about the needles which we use, so I'm not going into the details. Before doing a sampling, it is very, very important to identify and characterize the lesion as solid and cystic. Position the echoendoscope as straight as possible. You have wide array of needles available. 25 gauge needles are smaller, easier to use, produce less bloody samples, and increase yield, so they can be used by beginners. Insertion of the needle should be gentle. One should avoid excessive force, and the transducer should be brought as close as to the lesion as possible. The lesion should be positioned in needle path, so this will come with experience. You should not be having the lesion outside the needle path. That will make the tissue acquisition difficult. And the needle sheath should be adjusted in such a way that it is just beyond the elevator, because bringing it out to a longer distance will create artifacts and make it difficult to do the procedure. And after the needle sheath adjustment, the screw must be tightly wound, because otherwise the sheath will move in and out and cause trauma to the patient. And before puncturing the stopper, the device must be unscrewed to allow a precise needle development. And one can use an elevator to increase the angle between the needle and ultrasound probe to get a proper tissue acquisition. You should not be having any bend in needle, because if there is any bend, it will increase the resistance and make the procedure difficult. One should avoid puncturing undrained obstructed ducts that may lead to cholangitis or pancreatitis. And finally, before using a needle, one should scan the FNA path with power Doppler to exclude major vessels, which can lead on to bleeding post-procedure. One can use either a fanning or a multipass technique. In a multipass technique, you come in and out, so there are chances of more contamination. So it is better to use a fanning technique. And it is important to remember that transducinal FNAs are difficult as compared to transesophageal or transgastric FNAs because of the torqued root of the scope. So in these situations, the 25 gauge needles may be used. And similarly, access from gastric fundus is also difficult because of sometimes retroflexion may be required to acquire the tissue. So best location for tumor sampling is thought to be the periphery of the tumor, because you tend to have much more tumor cells as compared in the center where there is more necrosis. So avoid intervening vessels with Doppler, avoid ducts, avoid vessels, and try to get the periphery of the lesion to get a tissue acquisition. So these are the difficult situations for EUS FNA, which you should remember. Unstable scope position, difficult in positioning the lesion at a suitable location for puncture, lesions located adjacent to large vessels, the lesions which are mobile like just in the stomach, small lesions, hard lesions, hypervascular lesions are again difficult to sample. So in these situations, one may need a help of an expert once you are beginning to do an EUS. So finally, to conclude, I would again like to reiterate that there is no magic wand to learn EUS. There is no role for self-teaching of EUS through trial and error. One should go through a systematic and structured training. A comprehensive knowledge of anatomy is must. It helps in better training in diagnostic EUS. However, it is important to remember that EUS training can be done with time and dedication. Thank you so much for your patient hearing.
Thank you, sir, for that wonderful lecture. And thank you, sir, for that.
Malay, you are muted. Malay, can you unmute? Yeah.
So I think we have now questions and answers. So that was an excellent talk, Surinder. So one of the question is, what books you will recommend? If somebody wants to study endoscopic ultrasound or learn endoscopic ultrasound, what are the books?
Dr. Malay Sharma's book.
No, not.
I think first, sir, I will like to thank you for moderating this session. You have been one of the great teachers of EUS. You have taught generations of endosonologists EUS in our country. So I think regarding the question you asked about the books, there are a lot of books now available. One can go and read through any of the textbooks. The books which I have read was a book which was written by Shyam, Rob House, and Paul Fawkins. Otherwise, there are many other books also, but I think that's a good book for beginners to read.
See, my point is that in the books, whatever are available, the chapter on techniques is not so well written. What they say is they mention more on pathologies. So you have to read all the books, and if you go through all the books, there are many more books of previous authors.
Yeah, I agree with you, but I think there is no book which can replace a teacher. So you need a teacher to be, teaching you how to do an EUS.
Yeah, teaching how to do.
Can I ask a question, please?
Yes, Doctor.
Yeah, excellent talk, Dr. Anna. I just wanted, you didn't highlight anything about ROSE, as in rapid on-site evaluation. Is that a must? Is a beginner going to be aware that we should have somebody around? And because I think in the beginning of EUS FNAs, lots of times you have failures where you get up with a report, get a report that sample inadequate. So that's the one which I thought should also be earmarked. What is your say on that, Rose?
Yeah, thank you, Dr. Ajay. It's a very, very important question. As a beginner who is doing a tissue acquisition, you are going to have substantially higher failure rates. But the issue of ROSE vis-a-vis training has not been addressed by any studies, because we always presume that the person who is getting trained under an experienced endocrinologist. So that, like the protocol which we follow at our institute, is that if a trainee is doing a tissue acquisition, first pass is done by trainee, followed by second pass by the teacher. And with the availability of FNB needles now, the role of Rose is going down. So I think it's a good point that in a centers where the sample adequacy with tissue acquisition is, say, less than 90%, they should have Rose, especially the trainees are doing an FNA. But in the centers where your diagnostic accuracy with tissue acquisition is beyond 95%, which is true for all centers with FNB needles, the need of Rose is limited, because Rose also adds on to the cost, the time of the cytopathologist. So there are a lot of flips with Rose also.
Dr. Surinder, there is a issue. Do you think the time has come that you should shift over from FNAC to FNAB? Because both for diagnosis and management of different types of tumor, most of the oncologists and surgeons, they need tissue markers, IHC, which may not be sufficient on FNAB. If the cost is not an issue, if the size of the needle is not an issue, is it worth doing FNAB rather than FNAC and all?
No, I perfectly agree with you, sir. Now, I think the era of FNA is over. FNA is only limited for aspirating the cystic lesions or doing the transluminal drainage procedures if you don't have access to the cautery enhanced devices. The role of FNA is very, very limited. If you have an FNA, because now it's an era of personalized medicine, you will require the tissue for molecular markers. And I think if you have the facilities for molecular markers, you just even don't have to prepare the slides. Do an FNB, put the sample in the container and send it for complete analysis, including molecular markers.
Especially, when you have large lymph nodes and you are not sure whether you're dealing with lymphoma versus tuberculosis. So even if you have a diagnosis of lymphoma, certainly the pathologist certainly needs more tissue for putting in IHC markers for characterization of the lymphoma. So undergoing a second procedure is not only traumatic, but it is also not cost effective. And that is the reason I'm asking, should we routinely shift over to FNAPs? Comments of Saransh? Yes, sir.
Yes, sir, 100%. I believe that FNAB in places where you need further diagnosis, especially IHC, is much more simpler. And even when we do FNAB, this answers of negative results that coming in FNAC are much less. Even in learners, even in beginners, you have more positive outcomes because the tissue acquisition is actually more.
Yeah, Dr. Mohan, you have a question, query?
This is just futuristic for all the US experts. And now the emphasis is on cell-free DNA and circulating tumor cells. And cancer screening is going to be the future of cancer screening, where you collect a blood sample and you do the molecular studies and you can make a diagnosis, and subsequently you will do imaging to stage the cancer. So several experts have been, several very interesting papers have been published in the last 2 years, and that's going to be a future, I think. So even the biopsy, FNAB, will slowly get displaced, unless it is a very, very small tumor which you are looking for in people with familial pancreatic cancers. You're screening them, then probably in US and FNAB will be the practice. So
another question to Dr. Surinder is, Surinder, EUS is a part and parcel of day-to-day practice in gastroenterology. Why is it that we do not have a structured training program? Can you even name one center which gives you state-of-the-art training other than possibly Malays? Why is it that is so important and nobody teaches?
I think so. That's what the comment I was about to make, highlighting at the end of this talk, that we don't have any structured training program for EUS. It's a high time that we need to have a post-DM fellowship in advanced endoscopic techniques, including EUS. Why it is not there, I think it's a question which is difficult for me to answer. I think it's for the senior people probably to guide us how to have a structured training program in this field.
For the past 2 years in AIMS. It has been started for the past 2 years in AIMS. Advanced Intervention Fellowship.
Anil, I would like to say one thing.
Yes.
Whatever is the structured training program, that is vastly insufficient.
Absolutely.
And we have to do at least 50 times that much of a structured training program. Each center has 1 fellow or 2 fellow, 3 fellow. That is not on. And there is another word in structured training program is that you go right, turn this, turn this left. No. Like every CT scan, every MRI is different. You cannot put in structured description of report also into the training. That is ridiculous in my opinion.
Dr. Vivek call is there from US. Dr. Vivek, would you like to suggest to us in India as to what should be the changeover? And who else will take the lead? If Dr. Surinder Rana thinks is too junior, Saransh thinks is too junior, who else is going to take the lead? Vivek?
Hi, Dr. Anil, and hello, everybody. Good evening. It's about 11 a.m. in New York. Thank you again for inviting me to this conference. To answer your question, I think I can answer in 2 ways. In the US, we have EUS. I'm not going to say ERCP, but EUS training definitely available in the 3-year GI fellowship format in the 3rd year. Now, we've done that for about 15 years where I currently am. And in a high volume center, you can have the, a 3-year fellow in the 3rd year do between 450 to 750 EUSs with, 3 rooms running every day. I believe that volume and that complexity and that spectrum of disease is adequate to train somebody, who can come out and be competent at basic EUS with basic interventions such as FNA and pseudocyst drainage. Then we have the 4th year format, which is the 1-year additional after the 3-year fellowship. And we have no fewer than 80 to 100 programs, many of them in the ASG match. The problem there is that we have a wide variation in the volume and the disease spectrum. And of course, as was highlighted by Malay very accurately, the quality of the training as well. And so whereas we are doing a little better in terms of the platform and exposure and opportunity, I think gaps remain even in the US front where we could do something different. Now, recently, ASG has been involved in trying to look at this issue and along with experts in industry and experienced trainers, they're trying to create some kind of a combined national program where people could, but it's very, very early in its infancy, and also it's very difficult in the pandemic. The whole thing, everything has taken a back seat. I think for India, I think that you already have so much talent, you already have so much experience, but most importantly, you have the volume. And I think there are 2 ways to learn. One is high volume in short period of time, and one is relatively lower volume over a long period of time. So I think in the Indian context, the high volume exposure, so-called crash course in EUS, which would be 3 months, or would be more 3 to 6 months, something like that, or even shorter. It would be, I think, adequate with the right teacher. I think that would be how I would summarize it. And you have enough of those available. And I think to the extent we can help from 8,000 miles away in structuring such a program, in providing cognitive and endoscopic resources on the ground, we certainly can talk about it. I also chair the WGO endoscopy committee, and this could be an interesting program that we could put together under the auspices of the WGO, which India is a member of as well. Just throwing it out there.
Dr. Surinder, I have a question. At the time when we were trained, and you and I were batchmates, same parallel batch, US was not very commonly there in our institutes. So most of the time, people who have learned is after they have completed their training. But nowadays, the residents get to see at least the US, most of the centers do have. So, but most of us who had graduated early have are left out and not trained. So how difficult it is for us to learn now at a senior age. I know her, Dr. Anil Arora learned at very late age. I've seen him working and learning. But how it is difficult for a person who is much younger and compared to a person who is much.
You should tell me your age, no?
I'm 51.
51. So I learned at the age of 48.
Okay.
Okay. 2007.
You raised a very interesting point, but I think age is not any bar for learning. So you can learn at any age. And there is a very beautiful editorial written by Todd Barron in EOS. I think you should read it. He wrote it beautifully, Learning EOS in Middle Age. So he has beautifully summed it that it is worth reading it because, you know, any technology which comes is a technology of future. So if you want to remain in practice, you need to learn the future technologies. And I don't think so age is any bar for learning. One can learn at any age, and EOS is not difficult. You can easily learn with your skills of endoscopy in a month or 2 months.
Yeah, I was going to mention Todd's example as well. He went about 10 years ago, roughly, to AIG. We have trained, more senior individuals as well in EUS in a relatively short sabbatical. There's a person came from Pennsylvania many years ago. He was a very accomplished and high-profile surgical endoscopist, which we don't have that many even in this country. But he was in the lineage of, Ponsky and so forth. And his gap in his skill set was EUS. So we vetted his application and he came and he was there every day. And, he went back to the program and he established EUS there along with the ERCP colleagues. And, I was not unhappy that we got fewer referrals from that state because he was doing such a good job. So I think that paradigm is very important. It's a great question and it's been answered already by Surinder. So thank you.
We have Parveer Rai with us. Parveer, you have a high volume center. How many of your outgoing DMs will you rely that they'll do a competent job in diagnostic or say therapeutic US? Doesn't the onus lies on us, as happens in US, that after 3 years of training, you should be good enough to go independently? Does that happen? You are
muted.
Can you unmute?
Yeah. I think you have raised a very, very important question. And as everyone has mentioned about it, still in all centers, we are not giving the adequate hands-on training as far as US and ERCP is concerned. So the question that whether the trainee who passes out is reliable enough to do independent US, I think the answer is no. But I strongly feel that this 3 years duration for the residents to grasp everything related to gastroenterology and becoming expert in doing ERCP and US is possibly a tall order. So I think the way things are possibly in West, as Dr. Vivek has pointed out, I think a course of say 1 year or 3 years of fellowship or 2 years of fellowship, maybe an advanced ERCP is the way to go, which we have started, but again, not in a very organized way.
I would like to have one.
Yeah, we are happy to announce because of the lack of training in other specialities at Gangaram Hospital, we have started a course in certificate course in hands-on training in esophageal and anorectal manometry, which is something which has been missing. We have had an excellent help from Dr. Rajesh Senani, Naresh Bhatt, and Dr. Shobhana Bhatia. And hopefully with support of Malay, Veer, and Dr. Surinder and others, we are likely to start the same course in Gangaram after some time. We'll need your help. Malay, yes.
See, we are, as teachers or as seniors, we are telling. How many of us has asked the views of the persons who wanted to have passed out what they want? And I can assure you 99% of the want that they have devoted 3 years of their life in your department and they deserve at least 100 ERCP. They deserve to do at least 100 EUS. But hopefully the times will change. The onus is on you as teachers. This responsibility is yours.
I think just want to make one point. I little disagree with Praveer. I think we need to integrate EOS in 3-year training program because we are high volume centers. I don't think so. There is a need to add on 1-year fellowship. 3 years integrated because 3 years is sufficient time. So we can, with the volumes which we have, we can train them in at least a good diagnostic EOS. Maybe anyone who wants to practice interventional EOS can have a 6-month add-on fellowship for interventional EOS. But diagnostic EOS should be integrated in the DM curriculum.
Yes.
Ashish, can we wind up now?
Yeah.
Go to the next session.
Thank you, speakers and moderators and the panelists for this session. So we have to go to the next session now. The next session is an interesting session on cystic neoplasm of pancreas, diagnosis and management. And for this, I would like to invite our moderators, Dr. K.M. Mohandas and Dr. Praveer Rai. Dr. Mohandas is a senior consultant in Department of Digestive Diseases at Tata Medical Center, Kolkata. And Dr. Praveer Rai is a professor of gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. So over to you, Dr. Mohandas and Dr. Rai.
Good evening, everyone. So the topic of the next discussion is cystic neoplasms of the pancreas, diagnosis and management. The lecture will be presented by Dr. Vivek Kaul, who is the Siegel Watson Professor of Medicine and Chief of Division of Gastroenterology at University of Rochester Medical Center in upstate New York. And he is also a member of the Endo Lab at the same university. So he has been affiliated with various societies, the American College of Gastroenterology, the AGA, the SGA, and the World Gastroenterology Organization, where he has had a lot of contributions. Our panel is comprised of Dr. G.V. Rao. We know him very well. He is a very senior surgeon, director at the AIG Hyderabad, and chief of the GI surgery there. We have Dr. Ghulam Nabi Yato, who was the former professor and head of gastroenterology at SKIMS in Srinagar. We have Dr. Dinesh Garg, who is a senior gastroenterologist from Agra, and Dr. Ramesh Kumar Bansal, who is a senior gastroenterologist and hepatobiliary transplant consultant at Fortis Memorial Research Institute in Bhutan. So we start off with a formal talk by Dr. Vivek. Dr. Vivek, please.
We also have Dr. Sandeep Bhagat from Gangaram as a panelist.
Okay. I'm sorry.
Thank you, Dr. Malath, and thanks again to Dr. Arora for inviting me to speak here. This is again an amazingly insightful conference. You know, students of gastroenterology certainly need all the exposure and advice and training in endoscopy, but the cognitive aspect of GI training is addressed by conferences and seminars such as this. I must say that I've been listening since 8:30 our time this morning. Every lecture, every discussion is pointed, high quality, and really state-of-the-art. So congratulations to the team, and my great honor to be here and be included in this again this year. So with that, I'll try to share my screen and see if you guys can all see it. Is all good? Give me a thumbs up,
Yeah.
Anil. Is it good? Okay.
Yeah, absolutely visible.
All right. Very good. So my topic is cystic neoplasms of the pancreas, diagnosis and management. This is a big topic, like many of the topics today have been. I tried in this 20 minutes to put together some, obviously have to have some background, but try to put together some new stuff that folks may or may not have seen. The objectives of my lecture are to obviously review what is the published guideline recommendations, look at some landmark papers, some newer ones as well, talk about some consensus recommendations, some standard of care, opinion-based agreements. Of course, as always, I'm always interested in highlighting controversies and raising new questions. I'll touch upon a few new technologies that are at play and then some take-home points. So for early students and beginners, pancreatic cystic lesion basically divided into mucinous and non-mucinous categories in the cystic category there. Inflammatory cysts I'll leave out for the most part because that they are addressed in the acute pancreatitis lecture, but more of the focus is on IPMNs or mucinous cystic neoplasms, and then of course other entities such as serous cystic neoplasms, and then this relatively uncommon entity, solid pseudopapillary neoplasm, and then of course pancreatic cystic neuroendocrine tumors, which we see from time to time as well. So these are just characteristic images of serous cyst adenomas. This image here on the left is a classic honeycomb micro, maybe sometimes macrocystic component there in EUS. This could show up on the boards. It is a fairly representative picture when you see a classic lesion at EUS. So this is one of those pictures that actually is the same on the board exam and the same in the real patient. Over here is a mucinous cystic neoplasm, which is more of a anechoic, in this case, oligocystic lesion, maybe a partial internal septation there. But this is a classic cystic lesion in somebody who has not had a history of pancreatitis. And of course, in a patient who has had a history of pancreatitis, you have a large balloon-like fluid collection. In this particular case, doesn't seem to have any necrosis, so would classify as a simple pancreatic fluid collection or a pseudocyst, as is traditionally known. This is a branch duct IPMN, which looks like some type of a mural nodule there. And these are probably the most common findings in diagnostic EUSs that are referred to our clinical practices. Then there is the entity known as main duct IPMN, which is typically best seen on an MRCP, but can also obviously be seen on an EUS. The main duct IPMN is a pan-ductal involvement, which is the full spectrum. And then, of course, there's a segmental variant, which is shown here, which we also see from time to time. Now, this is the one where the dilatation of the main pancreatic duct is 5 millimeters or more. Often it is 10 millimeters or more. There is mucin at the papilla, and these patients are at the highest risk for developing cancer. And this is another classic image that fellows will see when they write their exams. This is no further information is needed. This is a patient who has main duct IPMN and should receive surgical consultation. Obviously, a more common variant, as I mentioned, is this branch duct IPMN or side branch IPMN, where a side branch of the main pancreatic duct develops relatively small, usually cystic lesions. They communicate with the main pancreatic duct, and their location can be really anywhere in the pancreas. And the overall lifetime risk of developing malignancy is much lower than the main duct IPMN. This is a seminal study, came out a few years ago from Harvard. They looked at their 15 or 16-year data, and about 577 patients with a clinical diagnosis of branch duct IPMN, so long-term study looking at what happens to these people. A median follow-up of 82 months is not bad. So they had two categories. One is a follow-up less than 5 years, and the other category is follow-up more than 5 years, which is the 2/3 of the patients. And overall, they came up with the conclusion that the risk of malignancy within 5 years is very low, 4%, and the risk of invasive malignancy within 5 years is even lower, 2.4%. And of course, risk of malignancy after 5 years is slightly higher because time is an important component. So these numbers are important. So compared to the 70% risk for cancer in main duct IPMN, branch duct IPMN in clinical practice at a high volume reputed institution, these numbers are quite telling and should inform us and help us inform the patient accordingly. So with that background, we all are aware that there is as many guidelines out there as there are countries potentially or continents. So AGA has one, ACG, European group, and even the radiologists have a guideline. So this has been a difficult, kind of a topic for many years at national meetings and such, and you sit there and you listen to these guidelines. So what I thought was, I'll try to summarize these guidelines based on a couple of important slides, which will be next, and then give a more of a practical approach to these guidelines, which we can have a discussion about in the panel discussion. So an important tenet that these guidelines refer to is worrisome features and high-risk stigmata. So what are worrisome features? Size more than 3 centimeters, enhanced in mural nodules, thickened and enhancing walls of the cyst, main pancreatic duct size is larger than 5 millimeters. This is an important one. Abrupt change in caliber of the pancreatic duct. So you have a cyst and the pancreatic duct upstream to this towards the end of the pancreas or towards the tail is dilated. That's bad news. Obviously, lymphadenopathy, which meets the criteria for malignant lymph nodes on EUS, which is a separate topic, is also bad news. And now has been recently shown that a serial trending rise in CA19-9 in the serum is also an indicator of malignant transformation. And of course, rapid rate of growth. So these are important features that students of EUS and those who deal with pancreatic cysts should be very familiar with. And this is really where the rubber hits the road. If these are the changes that are occurring in a patient's profile on imaging, this is bad news, and this needs to be, the patient needs to be brought in and a discussion needs to be had. So mural nodules I already showed before. This is an example of it, and this is a non-dependent kind of an entity on EUS. This is something that's not debris. It's actually attached to the cyst wall. And obviously our technique first is to aspirate the fluid, send it for the usual markers, and then target the mural nodule. And both of these can occur in the same pass, or you can have a second pass depending on the situation. High-risk stigmata are clinical. Again, some imaging, some clinical stigmata. A patient who has a cystic lesion who presents with pancreatitis or with obstructive jaundice, especially with B symptoms, is also bad news. And of course, an enhancing and enlarging nodule and a rise in the size of the pancreatic duct is also not good. So based on this background with the multiple guidance and so forth and these criteria that have been described, this is kind of my take on all the guidelines out there. This is an important slide, at least from my perspective. Surveillance and management of asymptomatic pancreatic cyst. Now, this is asymptomatic cyst. This is a patient whose typical referral has no symptoms, had a CAT scan for some other problem, and now has found to have this. So with further discussion, you find that less than 2 centimeter cyst with no high-risk stigmata, the consensus in the guidelines is to do a CT or MRI in 1 to 2 years. In the US, the standard has become MRI because of the less concern with radiation, but it's much harder to get approved with insurance. In a patient with 2 to 3 centimeter cyst with no high-risk stigmata, a surveillance every 6 months for a while, consider EUS, and then probably go back to an annual surveillance if the first few imaging surveillance sessions don't show any significant change. 3 centimeters or more, and if you're thinking this is a mucinous cystic neoplasm or a branch duct lesion that is now enlarged and has no prior history of pancreatitis, a surgical consultation has to be invoked if the patient is surgically fit, and certainly if the consensus is we are not going to surgery, then shorter interval surveillance and consider alternating EUS, especially if new worrisome features develop. And for patients who have high-risk stigmata and large cysts, more than 3 centimeters, EUS FNA is indicated. Surgical consultation takes a more serious tone and a low threshold for surgery in the appropriate patient. So this is kind of sort of the summary of all the guidelines. And obviously there are some variations, but we can have a discussion on that. Pancreatic cyst fluid analysis you can't get away from because that's the mainstay of what we do when we do EUS FNA. And I have to say that even today, after so many years, CEA levels are still the bottom line along with cytology where we make these clinical decisions. And the CEA level of more than 800 has a greater than 98% specificity for neoplasia, and that should not be ignored. Are there cases that have a high CEA and end up being benign? Yes, but you cannot make your clinical decisions based on that. So a high CEA with a low amylase, it's again for the students, this combination is bad news. This is the highest risk population when you are dealing with a sizable cyst. You just did an FNA, you have a high CEA and a low amylase, that is not good news. You have a low CEA and a high amylase, these probably represent the lowest risk categories, all other things being equal. Now, what about biomarkers? The last 10, 15 years, there's a lot of research on that. This is my takeaway slide on biomarkers. You can see here the different types of cysts that are listed here, ranging from IPMN all the way to non-neoplastic. and cystadenomas. Over here are the biomarkers. GNAS, of course, has received a lot of attention, but there's a variety of other biomarkers that are have been used in studies, and this review described it very well. So obviously in IPMN and MCN populations, you'll have the variety of biomarkers positive, and in the benign lesions, you'll have most of them negative. And the markers in red are associated with advanced neoplasia as a subcategory. So something to keep in mind. Again, I'm not sure all of us are doing these on a routine basis, but this is where the science is at this time. So my take on molecular markers is that DNA molecular analysis is useful in certain cases. And there are some commercially available tests available in the US that are being used at certain centers in indeterminate cases, especially when the CEA levels are in the intermediate range and the patient is a borderline candidate for surgery and so forth. The diagnostic accuracy and the prognostic value of these markers needs further study. And I think that's where the issue is not resolved yet, which we can discuss as well. So the question comes up is, when should we stop surveillance of pancreatic cysts? Well, it's a difficult question because the patients, at least in the US, are growing older, and I assume in India as well. Here is a very controversial issue, because when the AGA came out with, do every year for 5 years and then stop, most of the practitioners didn't agree with that. The ACT says, 7 years, the radiologists say 10 years, and they will not approve these studies beyond a certain age. However, the Europeans say we should survey forever. I do not know the Indian position on this, but we'll find out in the discussion. The question I have is, if the rate of malignant transformation for any disease increases with age, how can we then say that we, at 70 we are higher risk, and 80 we are probably lower risk? So it's another conundrum that we deal with, but we really don't have clarity on this point. Another point that has come up for review recently is antibiotic prophylaxis. This is a paper published in Gastro, which is very hard to get a paper in. Randomized control trial, 112 patients who got Cipro, 114 did not. And you can see here the infection rates were very similar. In fact, probably more events in the placebo group. So my take on this is that, yes, it's a good study. It's thought-provoking. But doing a single dose of an antibiotic or 1 or 2 or 3 days of prophylaxis thereafter is not a huge cost burden. And for the 1 or 2 patients who do get significant local or systemic infection, if we can avoid that, we might be better off. But again, something we can talk about. I don't think practice should change just based on one paper. So my approach for an asymptomatic pancreatic cyst is an office visit. As often as I can do it, and most of them I do myself. Some of them can be done with my advanced practice provider who works with me and has worked with me for more than a decade. We involve the patient in shared decision making. We insist on high quality cross-sectional imaging, and then we reserve EUS for specific indications and a subset of FNA for even more specific indications. I've stopped doing FNA for small cysts anymore for a number of years. Recently, we've added CA19-9 at least annually, and we want to trend that along with our imaging findings. But most importantly, the takeaway from my experience is that you have to involve other colleagues from other service lines as often as you need to, and have a low threshold for referral to surgery early when the appropriate boxes are checked. As I mentioned earlier, don't hesitate to do that. The more people involved in these discussions and deliberations, the better in the long-term outcome of the patient and for the provider's health as well. Who does not need an EUS is something that I talk a lot about. We have learned from our experience and from the published literature that EUS is not needed in everybody. So patients are inoperable. Their age and comorbidities limit endoscopy and sedation and anesthesia. They certainly should stay away from the endoscopy unit, at least in the American context. Cyst that develops in the setting of pancreatitis, of course, is an obvious phenomenon. A large macrocystic lesion, oligocystic lesion in the pancreatic tail or body tail area in a middle-aged woman with no prior pancreatitis is a mucinous cystic neoplasm until proven otherwise. This is a question on the US boards. And their entire objective is to test you whether or not you're going to do any testing or refer her directly to surgery. Referring to surgery is the correct answer. Incidentally found very small cysts can be followed on cross-sectional imaging. Symptomatic cysts, patients who have recurrent pancreatitis and so forth, in general, if they have a mechanical problem, it is typically solved with surgery, and futzing around too much with endoscopy is probably not a good idea. When imaging is classic for a known entity, such as a serous cystadenoma, then also it is usually not necessary to do an EOS, although the forces of clinical practice may drive you one way or the other. So with that, moving to the other section, new technologies for evaluation of cystic lesions. Contrast-enhanced EOS is not new, but its application to cystic pancreatic lesions is, in my mind, relatively new, at least in our society. We don't have a lot of CEUS going on for a variety of reasons, but the Europeans and, of course, all of you back in Asia are doing this a lot. It is a time-tested modality and has value in a lot of situations that I've listed here. But the characterization of cystic pancreatic lesions, as shown in this video, the one on the left does not have contrast enhancement, and the one on the right does have. And in case there's an occult lesion or a solid lesion that is there, or even for characterizing the actual cyst for mural nodules and thickening, it may have value. But then again, we're not doing this routinely in the US. We can talk about it, what your experience is over there. So this is a paper from 2015, 50 patients with branch duct IPMN with contrast enhanced EUS. It was performed and mural lesions were seen on EUS, and mural nodule height was used in 15 patients who underwent resection. And they found that the diagnostic accuracy of mural nodule height enhanced the CEUS accuracy to 98% compared to EUS alone. So this concept of mural nodule height using contrast enhanced EUS was found to be quite accurate for differentiating benign versus malignant branch duct IPMNs. And so that is something I wanted to highlight. This is another paper looking at the fundamental B-mode EUS versus contrast enhanced EUS for pancreatic cystic lesions. 70 patients out of 580 were retrospectively analyzed after cyst resection. This is a ratio for mucinous and malignant versus non-mucinous and benign cysts. And again, contrast enhanced EUS had a very high accuracy of 84% versus 64%, with a very high, very impressive p-value actually. And mural nodule height was also part of that calculation. So this is a paper that came out in endoscopy a few years ago, and again highlights the fact that contrast enhancement definitely has a role, and with appropriate criteria and metrics such as the measurement of mural nodule and so forth, a subset of patients will benefit from that evaluation. So what about confocal laser endomicroscopy? This is something we were involved with as the technology came out more than a decade ago. The idea here is to inject IV fluorescent dye and enhance the visualization at the 20 micron level, really almost microscopy, which the name suggests. And does it improve the diagnostic accuracy at the time of FNA? The concern early on, and why this technology didn't go through in the beginning, was related to inter-observer agreement, because the initial papers came out, there was a wide variation in the kappa value, and it fell out of favor. But this is a prototypical image. You have a 19 gauge needle, and the probe goes through that. The patient already has received IV fluorescein dye, and that need to start that again. So this is the classic image of the serous cystadenoma and superficial vascular pattern and a few other criteria. And then the next part of the video shows the stark difference between a benign lesion and now the papillary lesion in IPMN. So we have used this technology for a number of years, and these are quite reproducible images. You just have to be patient and hit the right spot in the cyst to locate this frondy papillary type of area there, right there. So, but then again, not being used daily in every cyst, and we can talk about that. So this is a paper from 2019, a prospective study where they basically used needle-based confocal endomicroscopy and looked at the area under the curve versus CEA and regular EUS, and it basically was superior performer, and that was pretty good data showing a very high negative and positive predictive values. And this is endocystoscopy with the basically the spyglass probe through a 19-gauge needle, and you can see the back wall. Again, something we don't do normally on a routine basis. Microforceps biopsy sampling of the pancreatic cyst wall is definitely something that has come around in the last 5 years. 19-gauge needle, the forceps goes right into the needle, into the cyst, and biopsies the back wall. That's pretty much a technique. This is a meta-analysis of 9 studies showing a diagnostic accuracy that is not as high as we would have expected it. And of course, published reports as well as personal communications of some serious complications related to intracystic and peripancreatic bleeding. So a technology that is useful, but to be used with caution. In the interest of time, I'll skip that and talk about AI a little bit, real quick. AI in pancreatic cystic evaluation is being used using the platform of radiomics. And radiomics is basically using extraction of image characteristics and applying the machine learning and deep learning algorithms to determine whether a lesion is high risk or low risk pancreatic cystic lesion. And these 2 studies are both taken from CT images, where basically the CT images were treated with an AI algorithm and trying to achieve an accuracy of distinguishing between IPM and mucinous cystic lesion, serous cyst adenoma, and so forth. So this is early work. This is from the AI technical world, not necessarily from the GI world. And this is another study looking at AI algorithms between mucinous and serous cystic neoplasms based on CT images, and the validation group 75% accuracy. So still a little bit on the short side, but this is supposed to go further as we learn more about this. So in terms of treatment, I know I'm a little bit over time, so I'm going to go very quickly. Ethanol lavage of pancreatic cystic lesions is not new. Ian Gann published this many, many years ago, and Ken Chang was involved with this. Bottom line is, in the early years of cyst ablation, a third of the patient had complete resolution, and the rest of them came back. More recently, about 8 or 10 years ago, John DeWitt's group looked at ethanol lavage versus saline, and they found that the ethanol was more effective when used alone against saline, and that the saline group actually had no resolution in the cysts, whereas the ethanol lavage people had about a third of them resolved. So the similar results to Ian Gann's study. Now, more recently, a few years ago, alcohol-free ablation has come into view. And this is a study where 30 patients were divided into ethanol versus saline initial lavage, and then main treatment was paclitaxel and gemcitabine. And again, with the chemoablation, 67 versus 61%, and the serious adverse events, 6% of the ethanol group and 0 in the saline group. So they were making the case that saline plus chemoablation is the way to go, and that alcohol is not needed. So more to come on that. In fact, I am not at liberty to show, but this year the program is not out. At the ACG meeting, there will be some more high-profile papers coming in on ablation with chemotherapy. So this is moving on to RFA ablation, which you guys are quite familiar with. This is a porcine study we did with the RF catheter and the ablation. It may or may not portray very well in this long-distance transmission, but you see a cloud of hyperechoic imaging that develops after the RF ablation catheter is in. These are the 2 platforms that are commercially available, the Habib catheter and the EUS RA direct probe. The question is, so far they're being used in solid lesions. The role in pancreatic cystic lesions is just being evaluated as we speak. And here is a study looking at prospectively at 12 patients, 14 of whom had neuroendocrine tumors, but 17 had cystic tumors, and that's relevant to this talk. And at 1 year after RFA of these cystic lesions, 65% had complete resolution, and all neural nodules had resolved. Of course, this type of intervention does come with a potential price, and I think that's what the longer and larger studies will tell us about. So controversies, finishing up here, controversies in pancreatic cyst evaluation in my mind, and surveillance and management, I think it's still unresolved, which is the, if you're just going to be doing imaging, CT or MRI, the pros and cons of cost, time, at least in our sense, insurance approvals, EUS, does everybody need EUS every year and so forth. Cyst fluid markers, we're still stuck with CEA and cytology. When will molecular markers be standardized and commercially available and actually accurate and prognosticate? We don't know. When not to do EUS and when absolutely to do EUS is a big training point. There's a lot of discussion in training earlier. Antibiotics for FNA for now is still the standard, but with more papers, we might move away from that. And the question I always have is, what does enhancement in pancreatic imaging mean? Does enhancement always signify neoplasia? I don't think so, but we can talk about that. Cyst ablation, where are we going? I think we're going towards chemotherapy and going away from alcohol, maybe with RFA, we'll see, time will tell. And then what do you do for a high-risk patient with main duct IPMN? Do you do the whole pancreatectomy or do you do partial? When to stop cyst surveillance? The questions are endless. I just wanted to give a flavor of what controversies still exist despite a great amount of work being done. Last two slides, take home points. Pancreatic cyst evaluation and management has evolved significantly. I think the surveillance guidelines are no doubt confusing, but all of us, each of us need to extract the main message from these guidelines and apply that to our patient in clinical practice. I tried to do that in that slide, but I don't know how successful I was. Novel imaging platforms and molecular testing definitely have made progress, but are not yet mainstream, at least in my mind. Who does not need an EUS is a very important point, and I think we have overused EUS in this realm, and that's open for discussion. High-risk stigmata and worrisome features are very important and to know and to act on, and indications for FNA in the cyst realm are more clear now. Microforceps is probably the most direct way of enhancing tissue sampling, but cyst size and complications potentially will limit to some extent. Artificial intelligence is coming along. I think like in every area, it will be applied to pancreatic cysts. I think we do need some help in this area, but the field is relatively in its infancy. But in my mind, multidisciplinary approach with shared decision-making is the best strategy for this population, which represents a large population in all our clinics. Thank you so much, and sorry for going over time.
Thank you, Dr. Vivek. That was an excellent talk. I think we are running short of time. So can I know from Dr. Ashish or Dr. Arora, how much time do we have for this discussion?
I think you can have 15 minutes discussion.
Okay, that's fine. So I think the summary slide tells us all that this topic is not that easy as has been shown in algorithms. So a point that I would like to make and ask Dr. Vivek to opine about that is that if you see the ACG guidelines 2018, almost in the algorithm chart that they have put forward, they have opined about doing an US FNA in almost majority of the patients who are going for surgery. So do you agree with that? Or do you have any subgroup of patients where you will take the patients directly for surgery based on imaging like MR without doing a cyst fluid analysis?
Yes, that's an excellent question. And I think it comes back to multidisciplinary management, right? So you have a 29-year-old girl who has a 10-centimeter pancreatic tail cyst, and she is sitting in front of you. Now, what will I change in her life by doing an FNA? How long in her life will she be? This actually was a case presented last Thursday at our pancreas conference. And of course, you can argue that, okay, well, I would like to, in the American context, patients want to know everything. They want to know more, and that's appropriate. It gives patients autonomy, and it gives them decision-making capability. But my answer to that was that, how long this patient is likely going to live to 80, 85 years of age based on US Census data. So are you going to do 70 years of MRI? So I think in that case, that is an abnormal finding, regardless of how you want to cut that cake. So that needs to, the surgical option needs to be very high on the list, and then let the patient make the decision. So that's a very clear-cut example.
Yeah.
But yes, there are patients routinely sent who have intermediate presentations where they're older, the cyst is not as dramatically large, hasn't done much over the couple of years and somebody finds it and sends it over, yes, we do have a kind of an intermediate threshold of sampling it, because, you know, at the end of the day, if you have benign characteristics on the cyst, you might not push that 70-year-old to a distal pancreatectomy or a Whipple, as the case may be. So every case is very individualized and has to be treated as such. That was my point in the whole thing. And I think the more people you involve, the better answers you get in an expert center, especially, and the patient benefits from that information, and then they can make a wiser decision as opposed to somebody wanting to do something randomly.
Yeah, so I think the whole pretext of doing this surveillance and multiple imaging modalities is to avoid surgery if it's not required, considering the fact that surgery carries some morbidity and mortality. So about the type of surgery that needs to be offered to these patients, are we clear about what surgery to be offered to what subgroup of patients? Is that clear, or there is some controversy in that as well? Dr. Vivek and then Dr.
Yeah,
Jivik.
I would have Dr. Rao obviously to opine on that. I think obviously for the standard larger lesions that are in the head or in the tail or the body tail area, the surgeries have been well defined. More recently, some of our surgeons have dabbled with what we call enucleation of cysts, and this is particularly for cystic neuroendocrine tumors that are well away from the main pancreatic duct. They're relatively smaller, and with the intraop laparoscopic or intraop ultrasound, they can actually localize the dissection margins very well. So that's the other thing. But I think the discussions always get more hard when you're looking at a Whipple, especially in a borderline candidate. I would submit that even though all of us have managed distal pancreatectomy complications in our career, I think distal pancreatectomy, especially laparoscopic and robotic assisted in the appropriate patient, is a very low morbidity surgery at expert centers.
Actually, I agree with Vivek. Actually, parallel to what has happened on endoscopic ultrasound, we should also realize that very good advances have happened on minimally invasive surgery. We talk about the spleen preserving distal pancreatectomy and block pancreatectomy. All these are the procedures that are practiced now, either laparoscopic or robotic, depending on the facility available. For me, actually, I would differ with Vivek that I would strongly depend on a CT imaging rather than an MR imaging. And for all body tail regions which are symptomatic, resectable, young patients, I think I don't think EOS gives us any additional information. And we are just over-investigating all these patients by doing all this molecular testing and all these things. These patients functionally fit, symptomatic patients, younger patients, good cross-sectional CT suggestive of this thing, I think they should go for surgery. Head lesions, obviously, because of the morbidity involved, I would agree, yes, we can over-investigate these patients. But even that, I think with centers which are doing high volumes of pancreatic surgery, I think we should not really over-investigate this patient unless and until the patient is not willing for surgical procedure.
And like anything else, I think, Dr. Rao, the pendulum is shifting in most communities. As I said myself, I mean, 10 years ago, we were sampling pretty much any cyst that would afford us 1 ml of fluid. Now we don't. Now they have to literally force me to get the needle because that's the right thing to do. There's enough publications now talking about higher risk of post-FNA pancreatitis in small lesions, and so I agree with that.
So body tail, absolutely no needle, please. I'm dead against this. Body tail lesions, resectable lesions, I don't think I should stick in a needle into those patients.
So the interesting irony is that the body tail lesions are the easiest one for the beginner and novice endosonographers to sample.
Yes.
So what are they going to do then? Head is difficult to sample. Body tail, you're saying not to sample. They should just go home.
Body tail lesions are good for the surgeons also. They are the good surgeons.
That's what I wanted you to highlight. So body tail is good for everybody. So, but no, I think the point is well taken. I think the age of the patient, the motivation of the patient, the skill sets available in the building, the imaging characteristics, and the collaborative approach to this problem solving. These are the bullet points that decide what's going to happen. And I think that's really a fact that doesn't get talked about much. In any area you see, when you have a random individual making decisions, the patient is left with not much choice. And you have an expert group bringing these cases to a conference, to a tumor board, to a shared decision making, then the patient makes an intelligent choice.
But Dr. Vivek, the problem is, the very lesions in the body and tail, especially in the size range of 3 to 4 centimeters, they hardly have any symptoms.
That
So
is
what
true.
is the criteria for surgery then?
So symptomatic cystic lesions are actually quite uncommon, to be honest with you. I mean, the majority of cystic lesions that have symptoms fall on the Pramod Garg side, which is the inflammatory. Yeah, I hope Pramod is still on. I loved his.
Without further evaluation, how do you take them up for surgery? Says 3.5 centimeter lesion in the body, he'll just be having incidental non-ulcer dyspepsia. You do a CT scan just because the patient wants it, you have an incidental pickup of the cyst.
So Dr. Rao, you want to answer that? How do you decide a 3.5 centimeter lesion in a 55-year-old CEO who comes to you? How do you decide that?
So the same lesion, actually, Anil, I'll say, suppose you're talking about 3.5, because of the anatomical location, the patient doesn't have symptoms. But the same thing in the head of the pancreas, obviously the patient will come back with some symptoms. So I think if you have good cross-sectional imaging and it speaks of any worrisome features, I think it's worthwhile to consider.
You will not need an EUS or further evaluation?
No. Body tail lesions, if it is CT is good, I'm done with it. No EUS, no sticking in needle. Because not only this, actually, see, you're talking about worrisome features, you're talking about malignancy in these patients. Actually, even for CA pancreas, I would absolutely say no for body tail lesions because you're spilling the cells into the peritoneal cavity. And any patient who comes for a body tail lesion after CA pancreas with a needle stick, we always advise them neoadjuvant therapy before taking up for surgery. This is the standard thing. So body tail lesions, I don't think you should stick in the needle at all.
If it's a benign lesion, say serous cyst adenoma.
Okay, that that you can follow. Yeah. If you're being confident there's a serous cyst adenoma, you can follow it up on and then keep a follow-up on this patient.
So I think how I understand Dr. Rao's position is that, we are assuming that you're dealing with a young patient with a high probability of mucinous cystic neoplasm, where they are looking at a long-term imaging and cost and, distress associated with a lesion that is pre-malignant. So let's be very clear. We're talking about ostensibly a lesion that, a 30-year-old will be looking at 60 years of imaging. That's what he's talking about. But for people should not take away that if you have a serous cyst adenoma, or if you have remotely even an occult pseudocyst, there's some history, something, if there's any confusion, that's not the patient you want to, take to surgery without further investigation. So I think it's there are nuances to this discussion. And I go back, the one area where I differ is, at least maybe because I practice in the US, is that you have to bring all the options back to the patient. I think we cannot be draconian about the fact that we do it this way or that way. And I think those interactions with the patient afford us to present to them our experience, our center's experience with the good outcomes and negative outcomes, and give them the probability of okay, which pathway would you rather go with? And of course, if they ask you, what do you think? Then you give them your opinion that, this is the most reasonable thing to do is to have surgery, or no, let's check it next year and go from there. So I think the discussion part is very important. And when Dr. Makharia was talking about his functional disease, I was thinking of the lecture. I was thinking that this same level of investment has to be made in these patients too. Now, we have, I think the correlate is very similar. We have as many pancreatic cysts coming in our clinic that, that the functional disease folks, experts have in their clinic, with unexplained abdominal pain, bloating and all that. And we have to spend the time. It cannot be a knee-jerk reaction. Okay, you come for FNA and you go to surgery, or you go away to another place. The discussion has to take place, which I find very challenging because that's why I get late in clinic.
Just a short question. Sorry,
just a short question. Vivek, you didn't mention anything about pancreatoscopy actually, either in your algorithms actually?
So the only place that has come into play is where you have main duct IPMN, and you are trying to, or actually more segmental IPMN, where you're trying to map out for the surgeon how much pancreas to resect. So I'll tell you, in my communication with those people who do it routinely or have done it routinely, and some publications, this is a field defect. Even if you are not seeing the fronds in 5 years, that location will have fronds. So I think it's overblown in my mind that pancreatoscopy will reliably direct the surgeon as to where to put the scalpel. So I think the question comes back to the clinical point is main duct IPMN. My feeling in a surgically fit patient is total pancreatectomy. That is not something you want to mess with. A segmental IPMN, which we see a lot, surprisingly, I don't know why we see a lot of that. Distal pancreatectomy may take care of the things, but that was my answer to the question. I'm sorry I didn't mention that.
No, basically, why I was mentioning, because right now we are running a multi-center international trial. When we are doing intraoperative pancreatoscopy using the digital spine, the shorter version of it actually now. And our own actually, even it's the same opinion from the other centers in Spain, one in France and one in Hong Kong, that about 25% of the patients seem to have skipped lesions. And we are revising the margins on table. So I think this data will come up very soon. So we feel that intra pancreatoscopy will play a big role for IPMNs and branched duct IPMNs.
Sure.
I think just a comment, the point that Dr. Arora made is, I think, very, very important point. 3.5 centimeter lesion sitting in the body and tail, and patient is asymptomatic. I think offering surgery straight away would be a tall order as far as we see the guidelines which are there to guide us. So if we see the ACG guidelines for this subgroup of patients, they do recommend or do suggest doing an US FNA. I think I would go to the other panelist, where we have a very eminent panelist with us. Dr. Yatu, would you like to make some point?
I think I totally agree with Dr. Rao that we should not over-investigate these patients. If we have a patient and we have done a very good cross-sectional imaging and we find that there is a mucinous cystic neoplasm, and I think this patient must go to surgery rather than over-investigating these patients. I would also like to put a point here that we had a cross-sectional imaging few patients where we thought that they have cystic neoplasms, and when the surgeon operated, these patients had hydrated cyst of the pancreas. So I think I would like to put this thing to the audience that in a place where hydrate is an endemic, this must also be kept as a differential diagnosis in cystic lesions of the pancreas.
Yeah, I think a very pertinent point Dr. Yatu has made. Dr. Sandeep, would you like to make a comment?
So I was just asking a short question. Which subset of patient would you like to take for ablative therapy? Like you mentioned ethanol and RFA and chemoablation.
So in my mind, ablation therapy is perfect for the older patient who has a high-grade lesion. Okay. Older means doesn't have to be 89 years old, but somebody who's 70 and onwards, who has some comorbidity that surgeons are not excited, has a relatively small lesion, and I would submit that a cystic endocrine neoplasm is a perfect. You take the solid component, aspirate the fluid component, and do the RFA there. So I think borderline surgical candidates, older patients, and patients who do not want surgery. There are a lot of patients who don't, who had a brother who had surgery and died or something like that, So I think those would be my top choices for that.
Okay, thanks.
Dr. Rinkesh, please. Any comments, questions?
So, what is the role of prophylaxis according to you? It should be given or not?
You mean antibiotic prophylaxis?
Yes.
Yeah, as I mentioned, I think the gastro paper is the best paper so far. There is another paper that came. So, my answer to that is, in general, I don't change clinical practice based on one paper, in general. Especially if the paper guidance is in the negative, which means take away from current management. Now, if you remember, the indomethacin paper that came out in New England Journal and the PSC paper that came out not to give ursodiol also came out in New England Journal. One of them was adding something One of them was removing something. So ursodiol has been removed from PSC management. Indomethacin has been added to ERCP management, right? So you have to look at single papers, small studies many times. They should not totally influence your clinical practice. I think common sense, clinical judgment, and your own assessment of what makes sense. Now, if you have one patient out of 1,000 who gets pancreatic abscess, is that worth it? No, it's not worth it. But of course, if you have an international multi-center randomized trial, if it makes into the guidelines, then you have to reassess it. Yes, but one paper should not.
I think we have exhausted the time. I would request Dr. Mohan Das to provide the concluding remarks.
Yes. So thanks, Vivek and all the panelists. The cystic neoplasms of the pancreas are getting picked up, because of various scans being done for various reasons. And over the last 3 decades, even in India, we tend to see a lot of these patients. And they are actually a large spectrum of disease with a very wide biology. The same malignancy same benign lesion can, for a period of time with just one mutation, change its course, and lots of exciting things are happening. And I think we have had a very good discussion about it. But my summary statement is, I think it is important that because of the complexity in the diagnosis and the biology, we must consider taking all our cystic neoplasms to an MDT before they are individually managed by individual clinicians.
Thank you.
Thank you, Dr. Mohan Das. Thank you, Dr. Praveer, for moderating this session. So we now move on to the last session of the day, that is advances in management of colonic polyps. For this, I would like to invite our moderators, Dr. Ajay Kumar and Dr. V.G. Mohan Prasad. Dr. Ajay Kumar is the past president of Indian Society of Gastroenterology. He is the chairman and head of department at BLK Institute of Digestive and Liver Diseases in Delhi. And Dr. V.G. Mohan Prasad is a senior gastroenterologist and hepatologist at VGM Hospital, Coimbatore. So Dr. Ajay and Dr. Mohan Prasad, over to you for inviting the speaker and introducing the panelist.
Well, thanks, Ashish. I think we are already late by more than half an hour. So straight we go to the speaker. Well, Mohan Ramchandani from Asian Institute of Gastroenterology doesn't require any introduction to any Indian audience. He's a teacher of teachers now at this young age. So he'll be talking to us about the advances in management of colonic polyps, a more common disorder now, as compared to what it was, say, 20 years back. We see much more of these than before. And we'll talk about the panelists after we come on to the discussion. I think over to Mohan.
Thank you, sir, for the kind introduction. And can you hear me?
Yeah,
okay.
We can hear.
Yeah. So at the outset, I thank Dr. Anil for giving me this wonderful opportunity. I think we are late in the Saturday night. I'll try to finish my talk quickly and we'll go to the discussion part. As colonic, as Dr. Ajay Kumar was saying, that this colonic neoplasia is now a problem, though we still rank, we have around 7th commonest cause of colon, the cancer among all cancers is colon cancers. But look at this place where the mortality is still very high. Out of 4.4, 3.4 people die. That happens because we diagnose most of our cancers late in the disease stage. And we need to do more about them getting picked up in stage 1, where mortality become much lesser as compared to what we achieve now. And that is why I'll spend some time to first how to diagnose these cancers and polyps, and which are the cancers, polyps, which needs more advanced treatment in the form of submucosal dissections, or what are the polyps which can be managed by simple polypectomy. So the first thing which we should know is the morphology. Once you see a polyp, you should be able to decide in which classification it lies. Why it is important, just by mere seeing a polyp, you can say that this is harboring a cancer or not. So a polyp can be in a Paris classification, the early cancers. I'm not talking about the deep cancers, but the early cancers, they can be either a polypoidal or non-polypoidal. The polypoidal is a pedunculated polyp or a sessile polyp, or a polyp can be flat, which can be divided into 0 to A, that is totally flat and slightly elevated, not as elevated as sessile. You have to put a closed biopsy forceps, and if the height is more than the closed biopsy forceps, you are having a sessile polyp. Otherwise, you can classify as 2A or 2B when it is completely flat, or then if there is a slightly depressed, it is type 2C. So once you see a polyp, you have to just quickly say that whether it is polypoidal, sessile, flat, or depressed. Why? Because if all polypoidal lesions, if you see, they are having a malignancy, a very less, 2.71%. As you go to flat lesions or slightly depressed lesion, you are having more cancers. While if you go to the excavated lesion, the cancer is high. So as the lesion is getting depressed, more cancer is coming. That is why we have now a classification of Paris classification. So if you suppose you see a depressed lesion, you will say that, okay, this may be already a deep cancer, and I will remove it in toto rather than do a polypectomy. Similarly, you will see the laterally spreading tumor. What is laterally spreading tumor? It refers to lateral growth of a lesion at least 10 millimeter in diameter. They spread horizontally in opposition to the traditional polypoidal lesion which grow upwards, or a depressed lesion which goes downwards. And all these LSTs are usually not of one type. They may be of mixed type, like the granular type, where you can see the polyps, multiple nodules. All granular polyps are good. Why? Because these granular polyps, which are homogeneous, they have some mucosal invasion of 0.5%. So remember, granular, good. While those which are non-granular, they are not good, because their submucosal invasion risk rise to 5% as opposed to 0.5%. Moreover, these granular polyps are not alone. They may be harboring bigger nodules. So this is mixed nodular variety. Again, as there is a mixed nodular variety, the submucosal invasion rises to 10%. While if a non-granular lesion becomes depressed, the submucosal invasion becomes 30%. So you are not even taken a biopsy, you are just assess the morphology of a polyp and are able to say that this may be an invasive cancer. Why it is important? Because if you are dealing with flat, small polyps, now polyps can be defined as diminutive, which are less than 5 millimeter, or small, or you can club them as less than 1 centimeter. They all require cold snare polypectomy now. So all polyp less than 10 millimeters, sessile polyp, will be removed by cold snare. We'll talk about that. While those which are pedunculated, if the head size is less than 2 centimeter, they can be just removed like a polypectomy. While if the head size is more than 2 centimeter and the stalk is bigger, you have to do a hemostasis first, prophylactic hemostasis by applying clip or by applying the loop. While, as I was talking about, these are the two very simple. If the polyp is sessile, less than 1 centimeter, remove it. But the polyps which we were talking about are endoscopic. Polyp removal will be decided by how much is the submucosal invasion. One thing we learned was, by seeing the morphology, you can say whether the polyp is submucosally invasive. Other things by which you can add on is by adding a image enhanced endoscopy. Now, if you see an image enhanced endoscopy, that will decide whether the polyp is submucosal just by imaging. Now, I will just quickly go to these three classifications. This is the NICE classification, where you need to see color, vessel, and surface, and will be able to say whether you are dealing with a hyperplastic polyp, which can be left alone, or adenoma, which can be treated by endoscopy, or deep submucosal invasive, which needs to be treated by surgery. How will you do that? So first of all, you just see color, vessel, and surface pattern. How do you see that? Now see the color of the polyp, it is same as that of background. So this becomes a hyperplastic polyp. Again, you can see this is the same as background. You can hardly see a polyp. Once you see a color of the polyp, you can decide. But if the color of polyp is darker than background, it becomes adenoma. Again, you have to see the vessels. If you are seeing no vessels on the surface of the polyp, or the vessels are thin, lacy, they again become hyperplastic polyp. But if the vessels become thick on the polyp, it becomes adenoma. So you are seeing the surface, you are seeing the vessels. The third thing is, again, the surface pattern may change. Now we have seen the color, vessel. The third thing is surface. If you see these dark spots surrounded by white pattern, it is hyperplastic. While if you see these tubular oval surface pattern surrounded by vessels, it becomes adenoma. So this is how we can quickly differentiate between a hyperplastic polyp or a adenomatous polyp. Hyperplastic polyp can be left alone, adenomatous polyps needs to be removed. While if this surface becomes amorphous, you can see there is loss of surface pattern, the vessels become too much of irregular, this becomes a type 3 polyp, and it is a deep invasive cancer and requires surgery. So this is the NICE classification. Unfortunately, if you see the NICE 2 classification, this is not able to differentiate. Type 1, it is easily differentiating. 95% it is correct that it is hyperplastic polyp, you can leave. Type 3 also it is 93% correct that it is in cancer, you refer this patient to surgery. But if you see type 2, which is adenoma or superficial submucosal invasive, this I will treat with EMR, but this I need to do ESD. But if I base my treatment strategy on NICE classification, I may prove wrong. That is why NICE classification may still be nicer. How can it be nicer? This was added by Japanese classification. This is known as Janet classification, which divided adenomatous type 2 polyps, NICE type 2, into type A, 2A, and 2B. By mere saying that if the vessels are irregular or obscure, then or the surface pattern still remains irregular or obscure, not totally gone, as is happening in type 3. If there is an amorphous area, loose vessel area where there is an interruption of the vessels, this they say type 3 and deep cancer, while this is type 2A is adenoma, type 2B is superficial submucosal invasion. We'll quickly see an example. This is the Janet classification. I'll just take few minutes because they are very important to understand. If you see this dot-shaped surface pattern, white surrounded by white, it is same NICE 1 or Janet 1, hyperplastic polyp. Again, you have to describe how it is look like, flat, elevated. Second polyp. Now this is a drawback of NICE classification. We cannot say sessile serrated adenoma in NICE classification. You can see these small lacy vessels and you will see the crypt opening. Once you see that, but everything remains same. This is sessile serrated adenoma. Again, this will be required to be removed by cold snare. Then comes adenomatous polyp. Again, dark surface, oval surface pattern, regular surrounded by vessels. It becomes Genet type 2A. This is removable by EMR, Genet type 2A. Again, now you see a polyp which is it's giving two pictures. One is surrounded by a very depressed area. This is and then there are vessels which are irregular. So this becomes Genet 2B and will be required to remove by endoscopic submucosal dissection. While this is a depressed area, and then there is a totally no vascular pattern, there is amorphous area, and there is no surface pattern. You can see everything is hodgepodge, nothing, you cannot say where is the surface, where this is deep cancer, this requires surgery. So by these classification, we will be able to say whether we are dealing with adenomatous polyp or deep cancer. But now we have endobrain available or endocytoscopy equipped with endobrain. These are now able to magnify the image by 520 times. And you can have a real-time picture of histology, not only by chromoendoscopy, but also by narrowband imaging. And this is what we are using now. We use endobrain eye to say this will prompt that there is a polyp. You go near it, and then once you go near it, you apply zoom with an NBI, you will see regular surface pattern. It will say it is adenoma, 96%. And then you apply chromoendoscopy. This is the methylene blue being applied, and then you do endocytoscopy. You will have a classical example. If you are good enough, you will be able to say, okay, this is adenoma. But here you will get an answer by machine, the computer, that, okay, this is adenoma, and I will treat it by EMR. So we have now, these are equally available. Unfortunately, in India, we have less training, and that is why we may be able to depend on the endobrain to tell us whether we are dealing with a superficial cancer or a deep invasive cancer, and this scores better. But I'll tell once the training is more, and this may not be, that statistically significant, but yes, it reduces a lot of stress from our mind. Then comes the treatment. Now we are very well equipped that how to do a treatment. As I told, if you find a sessile polyp less than 1 centimeter, it is now, you need not to treat by a hot snare polyp. You have to bring dedicated snare in your department, which are good for cold polypectomy. CSP, cold snare polypectomy. These are shield-shaped snares. The sheath is very stiff. This normal sheaths are very soft, but this is very hard sheath. The second thing is the wire. The wire is thinner, 0.3 millimeter as compared to 0.47 of the regular snare. So a combination of thin wire, stiff sheath, and shield-shaped snare, these are dedicated cold snare polypectomy snare. And you have to do all these polypectomy, whichever you see in the colon, you characterize it by narrowband imaging. Okay, this is adenomatous, and then you just snatch it by the idea is to bring first of all at 5 o'clock position, to take a lot of normal tissue and then just jerk and you will just get rid of it. Good thing about cold snare polypectomy is that you will see bleeding in front of you and you can manage it most of the time. There will be no delayed bleeding, and then there will be no delayed perforation. So you get rid of all the problems. And most of the studies have now, and guidelines have recommended that all the small polyps should be removed in this method. Once you do get a larger polyp, then you have to think about, now this is a particular case where you can see a polyp is there. You have to define, first of all, this is granular variety. This is elevated. There are no mixed nodulator. There is no depression. Then the chance of this being cancerous, deep invasive cancer is very minimal. And that is why you can treat this cancer by a EMR, piecemeal EMR, where you need to inject at the base, lift the polyp and work from one end to other. Here, the polyp required is, the snare required is bigger one, around 3 centimeters. Then again, you have to lift the base by injection of either saline or other thick viscous fluid, and then keep on doing the polypectomy. The results are same as that of ESD, because in this case, you have spent time to say that there is no submucosal invasion. You have studied the morphology, you have done the narrowband imaging, and then you have defined that this patient can be treated by EMR. Unfortunately, the piecemeal EMR is associated with sometimes incomplete resection, but recurrence are common, which are easily treated by next colonoscopy because they do not have submucosal cancers. But if you find a tumor, a polyp, which is like say non-granular, as I've told, there is a depression, tumor showing a different V1 pattern, which we will discuss sometime, large depressed type, or a mixed nodular variety. These are the cancers or polyps which you should not do EMR. You should always try to remove them by ESD. And this also includes tumors or which has been previously tried to be removed, and now they have come with fibrosis, or they are associated with ulcerative colitis and now has developed a polypoidal lesion, maybe early cancers. Here, aim is to do en bloc resection. Once you get an en bloc resection, our pathologists are in a better place to tell us about the margins. If the margins are negative, lateral margins and the vertical margin, there is no lymphovascular infiltration, there is no, that they are well differentiated, you have done your job. You have completely removed the tumor. I'll not go into the details of ESD, but here the thing is that you have to remove the en bloc, you have to keep on injecting in submucosa, separate the muscle layer from the mucosal layer, and you will complete this procedure. Maybe time may be required, but ultimately once you do a complete resection, and the best thing is once you get out the polyp, you can apply it on a board and then send this whole specimen to our pathologist, which will assess the curative resection. If there is not a curative resection, they may require additional therapies in the form of surgery or maybe oncological support. I think with this, I have finished my thing, but only thing my take-home message is we have to, first of all, diagnose these polyps in a macroscopic manner. What is the classification? Then you apply image-enhanced endoscopy. A size, a type of polyp, and image-enhanced endoscopy will decide whether you are going to treat these patients by endoscopic method, get rid of completely. You may not be expert in ESD, but yet majority of the polyps can be removed by EMR, which is very easy to do. There are very limited polyps which in colon, which requires high-end procedures like ESD. But if you spend time, you will be able to decide, okay, this polyp is superficially submucosal invasive. This requires en bloc resection and can be referred for ESD. And with this, I will end my lecture. And I sincerely thank Dr. Anil Arora Ashish, and whole Gangaram team for giving me this wonderful opportunity.
Thanks, Mohan.
Thank you, Mohanji. Oh, hi. Yeah, thank you, Mohanji. That was really a wonderful deliberation. We just enjoyed it thoroughly. So I just have one question with Ajay. Can I go ahead and ask the question?
Yes, please. You are the boss. You are the boss.
Oh, wow. Look at that. So I just wanted to ask Mohan, is there any role for endo ultrasound in staging these polyps? We don't see many of them using EUS to stage polyps. They just go ahead only by the surface morphology, the vascularity, and all the classifications of JNET and NICE. So is there any role for a radial EUS to stage these polyps?
I think the endoscopic ultrasound may be better for rectal lesion, but colonic lesion, it is almost out of question because we cannot do that. And moreover, in rectal ultrasound, if there is deep invasion, I think MR is much better to tell us about the mesorectal invasion. Apart from that, I think in routine clinical practice, EUS is not recommended to assess the depth of invasion of a colonic or a rectal polyp. Majority of the time, we will be able to say by the Paris classification, the LST classification, which I have told, and third is the image enhanced endoscopy.
Mohanji, one more question from
that was a masterly talk. I think Mohan in his talk has focused on how to identify the different types of lesions and to take a call whether the patient is for endoluminal therapy or go for surgery. And he's been able to sum up all the different classifications and put it in the right perspective. And talking about the JNET is probably a better thing than as compared to the other classifications. Mohan, correct me if I've understood it wrongly. GN, so we have a very eminent group of panelists here. We have GN Ramesh, which is again a past president of Endoscopic Society of India and from Cochin and the Esther Medical Center, and of course a dear friend. GN, what is your take? How do you take a call on deciding in the large, difficult polyps? I think the biggest challenge that we all endoscopists face is the lateral spreading polyps. How do you take a call whether you subject it to surgery or you like to go with an endoscopic therapy, or you like to go for endoscopic therapy with a polypectomy or a submucosal dissection?
I think it's a difficult decision to make. What I usually do is anything that is more than 3 centimeters, I'm very careful. And the problem, of course, is to look at the margins. Are they distinct, indistinct, as well as the fact that whether they can be, lifted up completely. These are all the factors that actually go to guide us whether an endotherapy is possible or not. If it is something that is really occluding the lumen, I really don't hesitate, and especially if it comes up higher, slightly higher up, I don't hesitate in sending them for surgery before. My question, of course, is that, we've talked about so much of NBI. NBI has been there for the last 2 decades. Endocytoscopy has come up now. My question is, will we ever see a day when these will replace conventional histopathology?
Whatever you do, my next question.
Yeah, and because my gut feeling is that no surgeon will probably go in for a surgery without a good histopathology, and so I think still histopathology will be the gold standard for time to come. My second question to Mohan is a situation where you have a pedunculated polyp which you take out. The histopathology comes as a focus of intramucosal CA. How do you really follow it up? Because I had a bad experience of a patient. I thought everything was okay, but about 10 years later, this patient came back to me with secondaries in the liver. So that I really burnt my fingers. So I do not still know how to follow these patients.
I think, shall I need to answer?
Yes, yes, Mohan.
Okay. So these two both are very pertinent questions Dr. G. and Ramesh has raised. One is the biopsy. So image enhanced endoscopy enables you to decide the treatment. Now, once you have removed the polyp, you still are not you are subjecting this for a proper histopathological examination. And that will decide whether this patient will require additional treatment or it is curative. Now, image enhanced endoscopy has been, it's successful in deciding. It's not completely, even if you see the guidelines which say that any imaging modality which is 90% sensitive and specific, not 100%, still can be used in deciding in imaging and discard, imaging and resect criteria. If I have an NBI which is more than 90% sure that, okay, this is hyperplastic polyp, I need not to touch, or this is adenomatous polyp, I'll remove and send this for pathology. Now pathologists say, look, I have received a histopathology and your margins are positive and it is undifferentiated, it is showing lymphovascular infiltration. I feel this will require further surgery. So in that way, image enhanced endoscopy has worked well. It has yet not replaced the histology. It has enabled us to tell in more than 90% way by which method you are going to remove a 10 centimeter laterally spreading tumor. If you do ESD in all, you will spend 6 to 7 hours. While if your image enhanced endoscopy is saying, okay, this is only mucosal, there is no submucosal, you can still do a EMR, send this for pathology, and then wait for their report. Still, I don't think they will ever replace the histology, but yet it has made our life much easy, made our classification easy, and we are now able to decide the route of management much better way as compared to blindly subjecting everybody for surgery or everybody for ESD, which is not possible clinically.
Do we have Dr. Manish on the panel here? I can't see him. Manish, are you there?
Yes, sir, I am there. I'm around.
Like Dr. Manish, another eminent faculty from Ahmedabad, everybody knows, of course, is another dear friend. Manish, do you think with more experience of artificial intelligence incorporated into the system, or a so-called endo-brain that Mohan talked about, and he published a paper on that, will be able to replace in future the histology? Will it come as a this thing? I mean, Mohan talked quite a lot about that, but I wanted your inputs. Or how do you foresee? He has already said that today it is not approved, and how do you foresee that? Manish can't hear you.
Sir, it is definitely something which is coming up in a big way, and Mohan obviously is fortunate to be working with an endocrine system. Most of us have only read and heard about it in conferences, but my gut feel is that this will also be just an added weapon in the armamentarium. It won't completely supersede the clinical judgment which we need to take, but an endocrine probably helps you avoid the mistakes of omission. It will probably point us out in those directions which we might have missed, the sort of polyps which are behind the folds which are very easily picked up by endobrain. And I think endobrain will also help in covering up native stupidity, which is obviously there many a times when people tend to be too quick. Mohan obviously can correct me on this, but I think endobrain has evolved in the last 5 years, and it's now becoming a very potent weapon. I'm not too sure whether it is still ready for prime time, but I guess in the future it will be something which will be a very, very useful adjunctive tool, almost like NBI, which will be incorporated in routine practice in the centers which have it.
Mohan, do you want to?
I totally agree with Manish, and it has been developed to reduce the human errors. and also overcome the shortcoming of less trained doctors available. Now, suppose there is a peripheral unit, a colonoscope is doing, he may miss one or two polyps, which may be very detrimental for the patient. But if there is an alarm over there, and at least if a polyp is detected, let us not characterize it, but at least he can refer this to a higher center rather than just doing a quick colonoscopy and saying it normal. So such type of, and also stress factors, by the end of the day, doctors may be tired or may tend to miss things. But here is a computer which is like a teacher on top of you, who will keep on saying that, okay, no, wait, there is a polyp, you need to characterize it. And if the characterization says, no, this is deep invasive or this requires a ESD, why not to refer these? So, but in a very high-end unit, it may not make much of difference. But in a less trained and high volume center where people tend to do more mistakes, it can act as a teacher on top of us to guide the proper actions.
Mohan, I have just a practical question. Very simple, basic thing. When you have a multiple polyps, where do you start, distal or proximal? And then how do you retrieve them? Because there's a challenge whether you do it. It's just a practical tip for there must be a lot of younger colonoscopists in the audience.
Yeah. So multiple polyps, usually if they are larger one, you have to, what we do is we complete the colonoscopy and start from the cecum and keep on cutting all polyps. Those which are less than 1 centimeter or those are diminutive polyp, you have to apply a trapper in the endoscopic end and try to suck out most of the polyp. If they are small, they will come. Otherwise, you have to go again and bring all the polyps and subject them for histopathology. There is no other way. But I go distal most, keep on coming out. And
distal mode means, just clarify, towards the cecum.
Proximal. Anatomically proximal.
Anatomically proximal, yeah.
Right.
Mohan,
Ajay.
Yes,
just let me just check. Do we have the other two panelists with Dr. S.S. Sharma and Dr. I actually don't
Dr.
recognize.
Deepak is there. Dr. Deepak.
Yeah, Deepak Chaudhary from US. Yes.
Okay, I'm sorry. Okay, Viji, you can go ahead with the discussion with Dr. Deepak Chaudhary. You can over to you.
Okay. Yes, yeah. Actually, I just wanted to I had a doubt. Like once, what happened, one of my close friend who's a doctor, his sister had a lateral spreading adenoma in the rectum, distal rectum, just 2 centimeters from the anal verge. It was circumferential 7 centimeter, but there were 2 depressed areas, and we suspected carcinoma. We didn't know whether it's invasive or in situ. So I started a dissection. As you pointed out, it took 7 hours for me to do an ESD, but I just removed it fully. And then this patient is on follow-up for 4 years, absolutely with no recurrence. My question is, if you do a piecemeal polypectomy, there could have been a chance of these, I know it is not submucously invasive, but could we have completely eliminated the tumor just by a piecemeal EMR? Will we be, probably producing a seedling or a chance of, a lesion left behind?
So that is the beauty of these Paris classification and image enhanced endoscopy. There are, as you have shown, your lesion was depressed. So it becomes 2A plus 2C, that is depressed lesion. And that makes a possibility that that can be harboring a cancer. Now, once you are a lesion which is morphologically looking like harboring a cancer, you want to remove in toto. You do not want, if you do a piecemeal, your pathologist will never be able to say whether you have done curative resection or not. But if you have a lesion on morphology, which is more suggestive of deep invasive cancers, like as your case, a depressed lesion, you have rightly done a ESD and then subjected this whole polyp to pathologist. She confirmed that, or he confirmed that the lesion is completely resected we see three aspects, whether there is a differentiation, then we see the vertical margin. Vertical margin, there is a curative resection definition for every organ. Like esophagus, if it goes beyond 200 micrometer, beyond muscularis mucosa into submucosa, that is the margin. For stomach, it becomes 500. For colon, it becomes 1000 micrometer. So in such situation, your pathologist should be very well trained. You are not only giving a pathologist a specimen, they usually say, okay, negative margins, but not. We also want to see lymphovascular infiltration. We want to see undifferentiated cancers. We want to see how deep it has gone. Even if the margins are negative, say submucosa is completely negative, but how much distance? If it is more than 1000, that means already the lymph node metastasis occurred. You have completely shaved off tumor. You have done a very good cosmetic surgery, but already the lymph nodes are there, which may not be picked up by any imaging, but after some time, as Dr. G.N. Ramesh case, maybe 10 years is too long, and I will not, but you may have a lymph node metastasis in 6 months to 1 year. So that is why morphology study, defining that morphology, image enhance, do complete resection, depend on the pathologist, all box ticked, okay, this is curative. Then you may have to think about screening for metachronous or other lesion rather than worrying about this particular lesion. But if the margins are positive, then you may have to do additional treatment also.
We are coming to the end of it. I'm sorry, Dr. Chaudhary, I missed you because I didn't place your name was not appearing. Okay,
That's fine.
Chaudhary, you have a wide experience. You people see people much more polyps than we see in India. And I just want to have this one basic question. With so much of newer modalities coming in to increase the pickup rate of the polyps, what do you think, which technology is going to be more acceptable without wasting extra time and making it actually useful to use all these technologies? And if you want, and simultaneously when you're on that, you can comment on any topic that Dr. Mohan spoke about and you want to interact, please go ahead.
Yeah, first I want to thank Anil for the wonderful program, and Mohan for the wonderful presentation on the colon polyps. My thing is, just in US, Medtronic, GI Genius was just got approved. So we don't have much experience, about the AI, which is one of the modalities to increase the detection of the polyps, because they claim it improves by 14% the adenoma detection rate. And every 1% increase in adenoma detection rate decreases the risk of interval cancer by 3%. So that's a very significant number. And my question to Mohan will be, should we all be using AI for detection of the polyps?
I think that's going to gradually come. Ultimately,
it's expensive though, but
we have to use it. If there is a technology and if there is a data which shows, and persistently we are seeing that coming up, how the AI is helping in increasing the adenoma detection rate. And you don't have to, they are all integrated in the scope. You need not to have a very fancy big machines or to incorporate that. They are just a push button technology and you cannot ignore that. And it is going to be there, and that will definitely, as adenoma detection rate is directly proportional to the lives saved, and they are going to come and they are going to stay. Well, this is my personal opinion. And
Mohan, I've got two quick questions before we close the session, because it's already 10:20. I think two quick questions from the audience. One is by Dr. Shrikant Gopi. One is that can we follow let's have quick answers. Can we follow NICE classification with Fuji or Pentax scopes? One. And second is, what is the difference? It's an interesting question. What is the difference between hot smear polypectomy with submucosal injection and EMR?
Okay. So I think EMR is the hot snare.
Hot snare polypectomy with submucosal injection with the, and EMR. What is the difference?
I think they are by and large same.
Yes.
They are by and large same. Polypectomy is usually referred to a pedunculated polyp, where we are removing a polyp or sessile, the sessile polyp or pedunculated polyp. They are polypectomy. But if you are dealing with a flat polyp, a laterally spreading tumor, we call it as EMR. But by and large, it doesn't make any difference.
So that can we follow NICE with Fuji or Pentax scopes?
I don't think so, because the NICE Fuji is BLI is coming up. They have got their own classification. But the other FICE method, which was there, is a post-processing. It's not an optical like NBI. So I don't think they will be able to classify the NICE classification by those technology. So they have not been approved.
Well, friends, you know, that's a very difficult to close a discussion, interesting discussion like this, but then time has its limitations and we are also limitations because of that. Well, Mohan has touched upon mainly, and see, this is a huge topic or advancements of colonic polyps. I'm glad that he touched on an area which was important and it was focused on that how do we differentiate between the different types of polyps and the challenges that we face in decision making in that. Of course, you could have gone to talk about the technical aspects of polypectomy, how to different behind the fold and below the fold, lower, upper. We could have gone into that. That's another big area. But it has given a very good insight into the classifications of the various polyps, the decision making, and how the endoscopist should approach. With that, I'll special thanks to all the panelists, of course, to Mohan for being patient and doing such a wonderful job out of this job given. And thanks, Anil, for giving us this opportunity to bring together experts and to discuss that. And over to you.
Thank you, Ajay. May I ask a question, a parting question to Mohan? Mohan, recently we removed a 4-centimeter polyp in the rectum. We spent 8 hours. I was wondering, just because we have a hammer, every nail should not be shoved into the wall. So why not hand it over to Dr. Rao? He will take half an hour with same sedation.
And give a bag to the patient? Do a API? No, I think there are certain... we cannot... these rectal polyp may require...
You're not talking about APR for this patient. I'm talking... See, there's a new technology, I think you should be aware, the transanal endomicroscopy, which is faster. The same polyp can be removed within 20 minutes, actually, what you're doing, especially the rectal ones. I think the rectal ones should be sent to the surgeon. All other proximal ones can be dealt with colonoscopically.
I just want to add this. Actually, recently we had our one senior physician colleague who had this rectal big tumor. Of course, it was looked blind. We didn't straightway hand it over. It was just at a rectal area. We just handed over to the surgical colleague who did the perrectal excision, and it went on smoothly. And the next day, patient was back home and to activity. Yeah, so both the options are available. You can keep on debating. I don't think there's any head-to-head trials comparing the two. But again, what the words that Anil used, that you will use wherever it comes to, I mean, it's an old saying of a surgeon that the barber's chair phenomena, it will happen like that.
I think LIMS also is a very difficult procedure, and very few surgeons can do that.
Very few endoscopists can do that polyp like you.
So that's what. So everything requires a learning curve.
Ultimately, it depends on the local expertise of it.
I think so.
And even for sigmoid lesions also, there may be a lower threshold for surgery, because nowadays surgeons are very adept at doing a laparoscopic resection.
Okay. Back to Ashish. Thank you. Yeah. Thank you, Dr. Ajay.
Thank you, Dr.
Thank you all the moderators and Mohan. Yes.
Thank you, Dr. Ajay. Thank you, Dr. VGM, for moderating this session. Thank you, Mohan. So we have come to end of this academic feast, third day of our clinics in hepatobiliary diseases. So we had 6 interesting topics. So to summarize, actually, Dr. Mandhir had to summarize, but somehow he got stuck somewhere. So I would like to summarize all the talks which had happened today in 5 minutes. So we had the first talk by Dr. Noria Yudo from Japan. It was moderated by Dr. Randhir Sood and Dr. Rajkumar Vadhwa. It was on endoscopic advances in endoscopic imaging. So he showed a lot of interesting advancements in endoscopic imaging, and he said that for detection and characterization of superficial GI neoplasm, recent evidences actually support the image enhanced endoscopy, and especially for magnification and for improvement in diagnostic yield of endoscopy. He told that newer endoscopic technology and artificial intelligence are the future, and they would facilitate achieving good images and interpretation of the findings. But he also said that it all finally depends on the brain of the physician who is making the diagnosis. So achievement of good diagnosable images depends on our hands, and the final clinical decision depends on the brain of the endoscopy. The next talk was by Dr. Govind Makharia on what is new in management of functional bowel disease, which was moderated by Dr. Deepak Lahoti and Dr. Naresh Bhatt. Dr. Govind Makharia said that to diagnose, we should now move away from calling these as a functional diseases of the GI tract, rather than these are the disorders of gut-brain interactions. And we should make a positive diagnosis rather than the diagnosis of exclusion. And we should also support the diagnosis by subtyping the disease, giving it a severity classification like we do for inflammatory bowel disease. We should define what are the comorbidities like psychiatric illness or such comorbidities. Then we should define the physiological abnormalities. And for the treatment, we have to use a multidisciplinary approach, and we have to devote time to these patients, and we should not ignore these patients. So it's a very important topic, and he told that 50% of these diseases start with the brain, from the brain. That means some past events, but 50% of these diseases start from the gut. So both types of these patients are there. The third talk was by Dr. Pramod Garg on current management of acute and pancreatic fluid collections. It was moderated by Dr. Subhash Gupta and Sandeep Laktakia. He told that acute fluid collections, if they have no necrosis, they usually resolve. But if the acute fluid collections have plus necrosis, the necrosis determines the outcome. And if the acute sterile pancreatic fluid collection would not require any intervention, but if there's infected necrosis, then initially we should try a conservative approach, and then we should go for either PCD or endoscopic drainage. And if that also doesn't suffice, then minimal invasive necrosectomy. And for walled off necrosis, if symptomatic, then endoscopic and laparoscopic approaches can be done. And there was an interesting debate about surgical results as compared to the non-surgical results. But it was felt that usually we should avoid surgery at the initial phase, but that is the initial phase actually determines the outcome. The next talk was by Dr. Surinder S. Narana on Diagnostic Eos for beginners. It was moderated by Dr. Malay Sharma and Dr. Saransh Jain. He told that Diagnostic Eos is actually a tough job, but it can be performed with dedication, and it requires cognitive and technical skills combined with endoscopic manipulation. And there's no magic wand, and a systematic approach to training can make it look easy. He emphasized that it should be supervised performance on patients, and there's no role for self-learning, and it has to be supervised by someone who is proficient in EOS. the diagnostic EOS comprises of two steps. One is correct image acquisition and as well as tissue acquisition. He told about linear EOS, which is very important for this, and how the transducer rotation and how we have to move our handle. And we have to take a 3-station approach for pancreaticobiliary EOS, stomach, duodenum, bulb, and D1, D2. And we also have to choose the correct echoendoscope. For example, for hepatic hilum, it is the linear endoscope, which is better. And for pancreatic tail, the radial scopes are much better. And he concluded that there's no magic wand and there's no role for self-teaching. And it has to be through a systematic and structural training, which is a must. And the comprehensive knowledge of anatomy is what is required, and it requires time and dedication. The next talk was by Dr. Vivek Kaul on cystic neoplasm of the pancreas, diagnosis and management, which was moderated by Dr. K.M. Mohandas and Dr. Praveer Rai. And he told about side branch IPMN as well as the main duct IPM. He told what are the worrisome features like size more than 3 centimeter, if there's enhancing mural nodule, and if there's thickened enhancing cyst wall, or if the MPD size is 5 to 9 millimeter, or if there's lymphadenopathy, or if there is elevated CA19 levels. And also high-risk stigmata are obstructive jaundice and enhancing mural nodule or MPD size more than 10 millimeter. So he gave a very important points that if the size is less than 2 centimeter with no high-risk stigmata, then the surveillance imaging can be done at every 1 to 2 years. If the size of the cyst is 2 to 3 centimeter, then surveillance should be done every 6 months. And we can consider taking advantage of endoscopic ultrasound. But if the size is more than 3 centimeters, then definitely surgical consultation is required. But if there's no surgery, then surveillance should be done every 3 to 6 months. And for more than 3 centimeter, US with FNA would definitely help. Then he told that if the fluid CEA level are more than 800, then it is 98% specificity of having malignant disease. Especially high CA and low amylase, highest risk. Low CA, high amylase, lowest risk. And for these patients, office visit counseling is most important, and shared decision making is important. And he also talked about needle-based confocal laser endomicroscopy, needle-based cystoscopy, and also role of artificial intelligence in pancreatic cyst risk stratification. He also talked about ablation by US and alcohol, and he also talked about controversies and these cyst management. And he told that it's a difficult thing. The last talk was by Dr. Mohan Ramchandani on advances in management of colonic polyps, which was moderated by Dr. Ajay Kumar and V.G. Mohan Prasad. And he told that the stage 3 cancers of the colon are the most common presentations, which is why it has got very high mortality rate. And he told about various classifications, especially Paris classification, which is very important when it is pedunculated, sessile, slightly elevated, flat, or depressed, and how we have to approach these lesions. And also the NICE classification, and what are the types in NICE classification, type 1, 2, and 3. And also the JNET classification, which is important, which has divided the type 2 into type 2A and type 2B, which is very important. And he also talked about endocytoscopy, and also he talked about cold snare polypectomy, and various other modalities like EMR and ESD. So these were the 6 talks, and we had very interesting discussion along with that. So over to Dr. Arora.
Thank you, Ashish, for very aptly summarizing all the events which had happened today. I'm so sorry for having extended the yawning and given a yawning gap between the finish line and the delicious dinner waiting for all of you. But I think you should give a credit to all the speakers, because if you have to listen to such excellent talks, you have to pay the price. If you have to listen to Mohan, you have to listen to Pramod, Dr. Vivek Kaul, Govind, and others who spoke today, you have to pay the price. And the price is a delay in the dinner. We're really sorry for it, but thank you so much for all of you for contributing very well to this scientific discussion. Good night and goodbye, and we look forward to see you at 6 p.m. same time. Thank you, everybody.
Thank you, sir.
Thank you.